Good morning, friends. Today our guest speaker is Shivashankar Timanpyati from Tata Memorial Hospital, Mumbai. He is going to lecture on nutrition in hematological malignancies. This webinar is brought to you by Mumbai Hematology Group, supported by Dr. Reddy's and managed by Perfect Square. I thank Mr. Ashok VK, Mr. Chirag Maithani, Mr. Ashish Jadhav, and the team Dr. Reddy's, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, the Executive Committee of Mumbai Hematology Group, a guest speaker, Shiv Shankar from TMH Mumbai, all our discussants who are themselves eminent hematologists or medical oncologists, and all of you for participating and sparing your Sunday, whether it is morning, afternoon, evening, depending upon the country to which you belong. To introduce you to the afternoon activity, today is World Thalassemia Day, and we've got a long webinar beginning at 3:15 p.m. right up to 9:30 p.m. on challenges in thalassemia 2022. Regarding the next week, we have a marathon activity from Wednesday to Friday, that is 11th to 13th of May, in the evenings from 7 o'clock to 9:30 p.m. And that is our 5th Academy of Clinical Experts meeting, the ACE. And this time, because it is e-meeting, so EACE 2022. It's an update in hematology, where we have got 6 international speakers. Dr. Santini to cover myelodysplastic syndrome, she's from Italy. Dr. Walid Galima from Norway to cover Altermopag in ITP. Dr. Michael Morrow from USA regarding chronic myeloid leukemia. Dr. Venucci from Italy regarding myelofibrosis. Dr. Zieser from Germany regarding graft versus host disease. And lastly, Dr. Regis Leto from France regarding aplastic anemia. So remember, Wednesday to Friday, coming week from 7 p.m. onwards up to 9:30. Our regular Saturday webinar on 14th of May from 7 p.m. onwards IST is on prothrombotic disorders by Dr. Rajiv Pruthi from Mayo Clinic, Rochester. And the next Sunday morning, we have our own Dr. Abhishek Kakru from Vedanta, Ahmedabad, speaking to us on everything about BCL2 inhibitors. So got a busy week from Wednesday to Sunday. Every day we've got something for you. Now to introduce the discussants of the day. And we've got a galaxy of people with us. Dr. Abha Dubey from Shalby Hospital, Ahmedabad. Dr. Akanksha Garg from GCRI, Ahmedabad. Dr. Anshul Gupta from SGPGI, Lucknow. Dr. Anupama Jagya from London Northwest University Hospital, London. Dr. Ashwani Sood from RNTCP Task Force, IG Medical College, Shimla. Dr. Deepak Charles from Esther MedCity, Kochi. Dr. Deepanjan Halder from Jupiter Hospital, Mumbai. Dr. Gopinathan from SGPGI, Lucknow. Dr. Gunjan Prasad from Apollo Hospital, Kolkata. Dr. Hamza Dalal from Fortis Group of Hospitals, Mumbai. Dr. Kripa Bajaj from Indo-American, Hyderabad. Dr. Kunal Goyal from Institute of Hematology and Transfusion Medicine, Kolkata. Dr. Leo Prince Manthan from KEM Hospital, Parel, Mumbai. Dr. Mahadeva Swami from Manipal Hospital, Goa. Dr. Aditya Murli from Esther Hospital, Bangalore. Dr. Nidhi Dikshit from Apollo Hospital, Kolkata. Dr. Parthiv Mehta from Jeevan Deep Hospital, Bhavnagar. Dr. Prashant Bhatt from KMC Hospital, Mangaluru. Dr. Priyanka Samal from IMS and Sim Hospital, Bhubaneswar. Dr. Radhika KK from Nizams, Hyderabad. Dr. Rajat Bajaj from HCG, Kolkata. Dr. Roshni Pandey from Mahakoshal Hospital, Jabalpur. Dr. Sadashivudu Gundeti from Nizams, Hyderabad. Dr. Satish Kumar from Manipal Hospital, Bangalore. Dr. S.P. Verma from King's George Medical University, Lucknow. Dr. S.S. Ray from Institute of Hematology and Transfusion Medicine, Kolkata. Dr. Smita Kayal from JIPMA, Puducherry. Dr. Stalin Bala from Nizams, Hyderabad. Dr. Subhaprakash Sanyal from Fortis Group of Hospitals, Mumbai. Dr. Thomas Kucheria, All India Institute of Medical Science, Bhubaneswar. And lastly, Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur. We now come to our Sunday quiz for the postgraduate students and others. As usual, whatever is your answer, you have to email to mbagarwal1@gmail.com. The winner will be fastest finger first. That means the correct answer that we receive first on this email. Of course, we are going to read out all the names who have sent the correct answer for this quiz today. This quiz is regarding acquired pure red cell aplasia. We are going to give you a case history and then put a question to you. So we have a 47-year-old guy working in the ministry at Port Blair. Was diagnosed of acquired PRCA 1.5 years ago, and he has been transfusion dependent. They had extensively searched for the etiology, and there was no tumor, including thymoma. There was no B-cell lymphoproliferative disorder, including CLL. There was no clonal T-cell disorder, including T large granular lymphocytosis or leukemia. There was no systemic autoimmune disease, including SLE. There were no infections, including parvovirus B19. There were no immunodeficiency disorders, and he was not on any medicine that can result into pure red cell aplasia. And hence a conclusion was made that this is a primary acquired pure red cell aplasia. He was treated partly at Port Blair and partly in Chennai. And he had received almost everything that one could do: cyclosporine, corticosteroids, rituximab, intravenous gamma globulin, mycophenolate, azathioprine, cyclophosphamide, methotrexate, danogen, and even a course of antithymocyte globulin. He didn't respond, and as all the ways were exhausted, he was referred finally to Mumbai for bone marrow transplantation. He had a matched sibling donor, but before considering bone marrow transplantation, a treatment was offered which worked, and he became transfusion free. And he has been transfusion free, and this is his 8th month. And the question to you is, what was this medical treatment, non-transplant treatment that he received, which made him transfusion free? So name of that medical treatment is to be emailed to mbagarwal1@gmail.com, and the winner will be fastest finger first. I'm going to keep this slide on for a few seconds. So you are looking for name of the treatment that he received, non-transplant, which made him transfusion free till today, and that's almost 8 months. Okay. Our next activity this morning is to present the weekly case profile. And the case for this week is Mr. PC, 68-year-old from Rajkot, has chronic lymphocytic leukemia with deletion 17p and TP53 mutation. He has constitutional symptoms and cytopenia, and hence he was put on the drug ibrutinib 420 mg daily. 3 months later, he develops headache, which is progressive, and then a left-sided hemiparesis. MRI brain showed a ring-enhancing lesion in the white matter, of the right temporo-occipital lobes. In addition, there were a few satellite ring enhancing lesions. So an elderly gentleman, CLL, which is characterized by some bad mutations, needed treatment, got ibrutinib for 3 months, developed some CNS symptoms, and his MRI shows something. That's his MRI, and that's his parieto-occipital lobe, and that's the ring enhancing lesion. Of course, the satellite lesions cannot be appreciated in this cut. Stereotactic brain biopsy showed branching, beaded, you can't appreciate the beads here very easily, filamentous organism. These organisms were positive on silver stain, and they were also weakly positive on Ziehl-Neelsen stain. The microbiologist suggested that this is likely to be nocardiosis. And that's the Ziehl-Neelsen stain. And the earlier was the silver stain. You can appreciate the beads much more easily here. The filamentous beaded structure, silver stain positive, AFB stain weakly positive. Patient was put on treatment with triple therapy using trimethoprim sulfamethoxazole, lenazolid, and imipenem. He received this for 3 weeks. By that time, he had a complete resolution of headache and his hemiparesis reversed. The treatment was de-escalated and he continued Bactrim DS and imipenem for another 3 weeks. And subsequently, he is continuing till today on Bactrim DS. A repeat neuroimaging showed 70% regression in the main lesion and total disappearance of the satellite lesions. The plan is to continue this treatment for at least another 6 weeks or maybe even more. As far as CL is concerned, he has been switched over to venetoclax and rituximab. As you know, ibrutinib is a highly active drug and is probably today the drug of choice for all categories of CLL, low risk, high risk, young, elderly, newly diagnosed, relapsed. Of course, it's the preferred drug when you've got a patient who's got TP53 mutation and deletion 17p. There is an association between ibrutinib and invasive opportunistic infection, especially a high rate of CNS involvement. Modern treatment of CLL does produce opportunistic infections. Most of the infections occur within the first 3 to 6 months of the treatment. As the time passes, you do not get them. However, the overall incidence of these infections is low and hence routine prophylaxis is not recommended. You see 3 neuroimaging here on ibrutinib therapy. This one is scedosporium, this one is aspergillosis, and this is cryptococoma. Of course, the imaging doesn't give you the diagnosis. You need to be an absolutely expert MRI specialist to even come closer to this, but the microbiology helps you. What this picture tells you that most of these infections on any of the drug, whether you're ibrutinib, whether you're adalimumab, whether you're on brentuximab, occur early in the first 3, 6, 12 months. And as you continue with the treatment, the risk of infection drops down. The mechanism of opportunistic infection following ibrutinib has been studied. There is inhibition of the function of the immune cells like macrophages, neutrophils, and T lymphocytes. And there's a change in chemo, attract, and cytokine environment. And these are the detailed changes that occur due to inhibition of BTK and ITK, leading to paralysis of function of B lymphocyte, T lymphocyte, macrophages, monocyte, and neutrophil. And that's the nature of abnormality in the center shown that it does. So ibrutinib is immunosuppressive. It's not just ibrutinib or Acala that produces this kind of immune paralysis leading to infection. Venetoclax causes neutropenia and infection, and the PI3K inhibitor adalimumab and duolisib cause dysfunction of T cells, neutrophils, and macrophages, just like ibrutinib, leading to infections. A word or two about nocardiosis. This is a gram-positive bacteria. It is considered as an opportunistic infection in immunocompromised host. However, there are people who get this infection even without overt immunodeficiency. And recent workup has shown that many of these who get this infection have got a single gene mutation leading to compromised immunity. Way back in 1888, while investigating a disease in cattle, a veterinary surgeon, Edmond Nocard, identified the gram-positive acid-fast agent. And after Nocard, about a year later, this infection was labeled as nocardiosis. The first report of nocardiosis in immunocompromised hosts was published many years later in 1954 in a patient of Hodgkin lymphoma. Nocardia has a specific tropism for CNS. When dissemination occurs, it can lead to symptoms like headache, seizure, mental state change, confusion, ataxia, focal neurological deficit, and a brain abscess may be visible on imaging. There is no serological test for nocardiosis. The clinical picture and radiology are suggestive, and therefore cultures are needed to diagnose. The diagnostic feature include partial acid fastness, which I showed you, resistant to lysozyme, and presence of these chalky white colonies, and the filamentous structure, which is beaded. It is important to keep the culture plate for 3 weeks because many of these grow much later. And because many labs don't keep it for 3 weeks, nocardiosis is underdiagnosed, especially if you are not immunocompromised and the clinician doesn't ask specifically for nocardiosis. The treatment of cutaneous nocardiosis is Bactrim DS, which is given for 1 to 3 months. For the lung, it is 6 to 12 months. And for disseminated, especially CNS, it is 12 months or even beyond. Other drugs also work, like aminoglycosides, amikacin, beta-lactam, like imipenem, linezolid. And modern treatment is a combination of 3 drugs as we use for our patient, which shortens the duration, and you can cut down the duration of even Septran maintenance, because that, when given for a year, can be quite toxic. And here you see a nocardia abscess in the lung. In a meta publication, these are published cases of nocardiosis between 1987 and 2020. This disease got attention after occurrence of AIDS and HIV infection. Interestingly, India has reported second highest cases of nocardiosis in the world after USA. So there's a peculiar geographical distribution. Now, the spread of infection can occur from the skin and lung to other organs. Usually from the skin, it goes to the lymph node, and from the lungs, it can go to the CNS. And the drug therapy, as mentioned, includes Bactrim DS, amikacin, dapsone, nafcillin, linezolid, and now imipenem. Well, we now come to the most important part of the day, and that is the lecture on nutrition for hematological malignancies. And before I invite our speaker, I'd like to show you a case, an importance of nutrition. This is Prachi, name changed, a case of DLBCL producing extensive abdominal lymphadenopathy. As you can see, as the distended belly here was all made up of lymph nodes, retroperitoneal, mesenteric, liver, spleen, pelvic, iliac, everything. And look at what has happened to her. Prachi is skin and bone. There is nothing left. All the bones are very, very prominent. Look at her forearm. So that's Prachi lymphoma, weighing 28 kg when she presented to us. This is Prachi when she was healthy, when she didn't have lymphoma. She had good amount of subcutaneous tissue, fat, muscles. She wasn't skin and bone. You can hardly see any bones. And she weighed 48 kg before she got her lymphoma. And that's Prachi after the treatment, almost about a year later. And she weighed now 56 kg, a beautiful young lady. You want to compare it? This is when she came for the disease, and it is 1 year after the treatment, skin and bone, and she's got muscle on the fat. With this introduction, let me have the pleasure of introducing our speaker for the day. Shiv Shankar Tibanpyati is clinical nutritionist and dietitian at the prestigious Tata Memorial Hospital, Parel, Mumbai. He is Vice President of Indian Association of Parental and Enteral Nutrition, and is Vice President of the Asian Nutrition Society as well. I request him to deliver his talk.
Thank you, sir, for that introduction. I'm just sharing my screen. I hope my screen is visible. Someone can confirm that.
Yes.
And am I audible?
You're audible, but there's a problem with your mic.
Okay, yeah. I'll just disconnect my earpiece here. Just a second.
No. Hello.
Much better. Excellent.
Yeah, thank you so much, sir. And thank you once again, Dr. Agarwal, sir, and Dr. Reddy's for this opportunity. And of course, Mumbai Hematology Group. So let me speak on nutrition in hematological cancers. To begin with, I actually divided the presentation into two aspects. One is the general cancer, and then I'll be proceeding into the specialized area of hematological cancers. When we see cancers, most of the times the nutritionists just forget about what all the things which we fail to identify. And some of these factors, what we see over on the screen, each factor actually has an implication on the diet planning. And as none of the nutrition colleges or any kind of courses do address any specialized education on how to handle the cancer and the specialized cancers, organ specific as well as even the treatment specific ones. So whatever during our experiences and a little bit of work worldwide, what has been done and published, and gathering all those informations and this compilation I have done. And this compilation, actually, I use it to educate to, there are certain courses in Dr. BMN College at Matunga and IAPN course, Indian Association for Parental Enteral Nutrition, they too have a onco-nutrition course. So this I use it for the purpose of the students, more or less. So I just excuse myself saying that I'm using the same presentation. So it has a lot of animations. I know the professional presentations doesn't have a lot of animations, and it's just the matter what is been projected. So these are the inflammatory markers what we fail to identify when we look at the patient, and we just focus on the area of malnutrition. The moment the patient comes into the our nutrition clinic, we just want to see whether the patient has lost his weight or does the patient has any kind of a symptom. The symptom may be a disease oriented, or it may be a side effects of the any kind of a treatment as well. So the main aspect what we fail to identify is the inflammation. So this is where we fail upon, and this is where I keep on telling all nutritionists as well to identify the inflammation first, because malnutrition is just the outcome of the inflammation, and it is not the primary concern for us. It is actually the other way around. The inflammation starts all symptoms, and the symptoms induce the malnutrition. Whereas we always see patients in a very totally different aspect. We see malnutrition and we forget about the inflammation. Let us try to understand how the inflammation has a direct role over here, because nutrition happens to be a slightly controversial area. And we all know that any person on this earth can speak about nutrition in any kind of a disease. So that is where we slightly need to really understand why a clinical nutrition has a different approach and as a different rationale compared to any kind of other nutritional advices. Over here, this 2017 paper, which really addresses the glucose metabolism in cancer cells, very well explained, and I'm going to address this issue for this presentation. We all know that Dr. Otto Warburg in 1924, he explained where the cancer cells and the healthy cells do differentiate over here. But we have failed to understand its implication on the human being or the metabolic activities, actually what happens into the body. So we just know that there is some discrepancies in the utilization of the glucose when it compared to the healthy cell and glucose cell. What he mentioned over here, he says that the glucose, when it is been consumed by a normal cell, the mitochondria produces 36 molecules of ATP. Whereas a cancer cell, when a single glucose molecule is being utilized, it produces only 2 molecules of ATP. So what happens to the energy, which was the 34 molecule of ATP, which is being lost? Where did it go? So what happened to that part of energy? So actually, he says that that part of energy gets converted to the lactate over here. So we are losing our energy in the cancer patients by producing a lot of lactate, which is acidic in nature. And that is where, even after consuming a good amount of calorie and protein, the patients are not able to put on weight, because most of the calories are not being produced, and most of the energy what the patient has consumed is being converted to the lactate. So what we can understand from the Warburg effect is the cancer cells are more metabolically active than all other healthy cells, and they use more energy. That is what we call it as a sugar. And there comes a lot of controversies whether the sugar feeds cancer cells or sugar doesn't feed cancer cells, and all those controversies what we come across on the websites or during our practices also, which we normally come across people asking why you are restricting sugars for the patients. So I'm trying to explain you in the next few slides why the sugar restriction is more important and in what way it is going to help the patient. And even if you are going to feed sugar as a source of energy, will the body is going to utilize that source as a energy source, or it is going to utilize as a to produce lactate? So we don't want more lactate to be produced in the body. In any way, we know it is acidic nature, and acidic nature is more favorable to the cancer cells. So definitely we don't want to contribute anything which is going to hamper the patient. At the same time, we have to see that the patient doesn't get malnourished as well. So we have two different approaches over there. We need to address the malnutrition also, and while feeding also, we have to see that the calories coming from which kind of sources are going to be more healthy for the patients. Let us see the cancer cells and lactate relation over here. The malignant tumors often have an increase in glycolysis associated with an increase in lactic dehydrogenase activities, which converts pyruvate to lactate. That is what the Dr. Warburg did explain about that one. Therefore, there is an increased serum LDH and lactate in patients with cancer. So this is what I said. I want to reduce the lactate content produced by the cancer cells so that the treatment can be more effective. And the patients may have a less side effects and will have a better outcome and maybe in a better position to complete the treatment. And not only that one, the recovery and thereafter the survivorship will also be a very healthy one. Further, coming back to the same thing, what the lactate is said, I did mention about what happens to the lactate. It's an acidic medium, and this acidic medium is very beneficial for the cancer cells to proliferate and grow. Further, this lactate, what happens is when it enters the liver, and the liver through the Cori's cycle, it converts the same lactate to the glucose. And this glucose again goes into the circulation, and the cancer cells use this glucose, and again they produce a bit of lactate, and the same lactate is again converted to glucose in the liver. So the Cori's cycle also, we want to reduce this Cori's cycle activities. As much as we succeed in reducing the Cori's cycle, the less lactate will be produced. So high lactate levels often have a worse prognosis, and because it promotes angiogenesis. As I said, as a nutritionist, I want to see that I don't contribute anything through my diet to produce too much of lactate, and this lactate is going to impact the outcome of the disease, as well as lactate also is going to reduce the immunity of the patient as well. The more the lactate, the more compromised the immunity as well. So that is why the lactate has a lot of negative impact on the patient's body. So the cancer cells, they know how to use this lactate as a waste material, and it is using its own waste material to produce the energy. It is the reusage of the waste what it is being produced. So we don't want this circle to be continuing over there. Warburg failed in explaining why this happens. He only spoke about what is happening. But when he was questioned that can you give the rationale why there is a change between the behavior of the cancer cell and the healthy cells, so there he was challenged. But after 5 years, Dr. Crabtree came with the explanation why it does happen over here. So he did mention that when there's a glucose uptake into the cancer cells, a lot of proliferation do take place, and there is an increased reactive oxygen species which impact the mitochondria and damages the mitochondria by the increased calcium deposits. That is why the mitochondria in a cancer cell behaves differently compared to a healthy cell mitochondria, where the healthy cell mitochondria is producing 36 ATPs, whereas a mitochondria in the cancer cell is producing only 2 ATPs. Further, this is just a data of 2018-19 of 10,000 patients, what we have seen in nutrition clinic. A very rough figure you can see, we found that among all those patients referred to the cancer patient, to the nutrition clinic, 27% of these patients were diabetic, and other than diabetic, 29% were hyperglycemic. They were not diabetic, but they were hyperglycemic. Only these two areas contribute to around 64-65% of the total patients, if you can see over here. So it means that these two category of the patient directly require simple sugars to be reduced as far as possible into the diet. As I said, these are the non-diabetic ones and they are hyperglycemic. Of course, there are other areas which again requires a restriction of calories or the restriction of some simple sugars. They happen to be those patients who are overweight or obese, and even the inflammatory markers which has been exhibited by the hypoalbuminic condition. As we don't have serum albumin levels of all the patients, but whatever the patients we had, out of which 42%. So I'm going to be wrong, even if I say even all the patients' albumin levels were available, it would have been near to 50% of the patients who were into the inflammatory condition. So hypoalbuminemia is a indication of inflammation. So maybe the nutritionist or the dietitians will take a clue from here and try to give an anti-inflammatory diet rather than giving a just high calorie and high protein diet just to maintain the weight, which normally fails. It doesn't ever give you the result unless until the inflammation comes down, the patient is not going to gain weight. And the guidelines are very clear. When you want to really address the issue of weight gain or weight maintenance, try to bring down the inflammation as well, or else your diet has nothing to do with any kind of inputs for the betterment of the patient's well-being or maybe the treatment outcome as well. Further, if you see, we saw that 57% of the patients were experiencing anorexia, and anorexia is again an inflammatory symptom. What we can take a message: if the patient is anorexic, if the patient is hypoalbuminic, if the patient is hyperglycemic, if the patient is overweight, obese, they all need to be addressed the inflammation as the first priority. Then you look after the how much of calorie protein you need to be provided, whether to maintain the weight, to increase the weight, to decrease the weight. That's a secondary aspect which comes over. Very briefly, again, I would explain over here that when the tumors are existing into the system, then we know that TNF alpha is one of the culprit which we really don't want to be there into the circulation. And this TNF alpha actually what it does is it increases the tryptophan, and this tryptophan gets converted to serotonin into the brain. And this process again is going to induce the anorexic part into the patients. Of course, there are certain ways where it can be, the tryptophan conversion can be reduced. The research is still going on, and maybe the TNF alpha contributing to the increase in the tryptophan, whether we can reduce that one. Again, we don't have a definite answer for this. A lot of research is still going on to work out on either to reduce the production of TNF or the impact of the TNF in conversion of production of tryptophan, or the tryptophan getting converted to serotonin, or maybe serotonin can be made nullified over here so that it cannot induce anorexia. So maybe in the next 3-4 years or 5 years, we will have a very definite answer. So we just need to wait and see how far good research is going to contribute to our dietary practices. Okay. So once there is a tumor, as we know, there is a miscommunication between the tumor and the brain starts sending the wrong signals, and the lymphocytes, macrophages, and TNF alpha starts releasing into the circulation. And through this circulation, we know what are the culprits. What we are actually are scared is the IL-6, which is going to increase the inflammation. Then we have IL-1, which is going to increase the plasma concentration of the tryptophan. what I told earlier in the slide, we don't want tryptophan to be increased. If there is a higher production of tryptophan, there will be a higher conversion to serotonin, and the higher the serotonin is converted, the more damage it is going to do the patients as well. So further, as I said, the TNF alpha, what it does is it increases the gluconeogenesis. Even if there is a provision of, even if there is a supply of exogenous calories, the TNF alpha will still go on utilizing the fat deposits and the protein deposits from the body. I'm saying even when the calories are being supplied exogenously, still it will act on the lipolysis and promote proteolysis, breaking down the fat deposits and the muscle deposit, the muscle protein deposits. So that is why the TNF alpha is again a harmful thing. As I said, their main goal is to break the glycogenase brain barrier and enter to the brain, which normally it takes a lot of time, but after some time, yes, they do succeed, and endothelial cells do act as a receptors, and they help them out to proliferate into the brain. And then there is an increase of plasma concentration of tryptophan, which again I repeat that it increases serotonin, and this serotonin, even though it's a carb craving, it induces the carb craving kind of a symptom to the patient. So whenever there is an increase of serotonin, you will see a patient coming to you and saying, many of the times when we ask the questions like, what did they consume like? And if the food consumption is reduced, normally what they are consuming, they will say that normally I take around 2 to 3 glasses of fruit juices a day, but I don't eat I don't want to eat anything. So what it is like, fruit juice is nothing but a pure carbohydrate, and a bad carbohydrate, what is going to get it? And this is where he can drink more fruit juices as well. He's saying he's drinking just 2 to 3 glasses. But if given a free hand, if the fruit juices are quite cheap and very cheaply available and easily available, they can even drink 5 to 6 glasses of fruit juice throughout the day without eating anything else. So why this thing of a phenomenon what we see in an anorexic patient? An anorexic patient should be saying that I don't want to eat anything, whether it's a fruit juice or a normal food, or it may be any kind of a snacks. Because anorexia is very clear. The patient doesn't want to eat or drink anything. But here there is a selection of certain kind of carbohydrates to consume. This happens because there's an increase of serotonin over here. Then we have IL-1, which once it is there into the brain, which is actually known for the responsible for the food intake by the patients. And what IL-1 does is it reduces the GI motility, thus making the patient to complain about delayed gastric emptying and gastroparesis, or maybe he says that if I eat in the morning, the next 5 to 6 hours I don't feel hungry. So then there's a reduced secretion of HCl. There is a increased chances of infection, and again there is a opposite kind of phenomenon happening. That is the ghrelin secretion, which needs to be higher, that get reduced, and leptin secretion, which needs to be lower, that gets increased. So that is why the patient doesn't want to eat anything, and all these things are contributing to the anorexic part, and the patient just goes down in the calorie consumptions and is into the malnourished status. So then there is a sarcopenia which sets in. Once the sarcopenia sets in, there is a signal transducers activators of transcripts, which is known as STAT3 in short forms, which is deposited in the muscles. And once the muscle starts breaking down, and who is breaking the muscles? The TNF alpha, what we saw it over here earlier, the TNF alpha, which is going to break down the muscles. As the muscle starts breaking down, we are getting more and more STAT3 produced and into the circulation. These STAT3, what they do is they increase the cytokine-induced pathway, which are responsible to reduce the development and to reduce the homeostasis, and they increase the proliferation and differentiation. Further, it is going to contribute to the sarcopenic condition of the patient. Once the patient is sarcopenic, there is an increase of resting energy expenditure. Now I want to give more calories to the patient. When there's an increased resting energy expenditure and the patient is anorexic, how is that I'm going to give good amount of calories? Adequate amount of calorie protein provision is something is a very big challenge for such kind of a patient. So we are dealing with something with a lot of resistance from the disease, and the demand is a lot of things to feed the patient. Now we are into the two positions. Should I only feed the patient or should I nourish the patient? So here we go wrong. The feeding is a very easy thing. The patient itself does feeding to himself. As I told earlier, even if he is anorexic, he will just feed himself through many glasses of fruit juices, but he will not eat anything other than the fruit juices or the sweet things which are nutritious. So these are the challenges what a dietitian would come across. As I said, there's an increase of resting energy expenditure. Mostly it is being seen in pancreatic and lung cancers, but not in colon and stomach cancer. That's one encouraging thing. Then we have some patients complaining of thermogenesis, and this thermogenesis again going to reverse the actual actions what is required, that reduces the anabolism and increases the catabolism. So thus we have a malnourished patient which is reporting, as sir showed one of the patient, that is the 28 kg patient what you showed. So I might relate this phenomenon to that case as well. This is the citation from where I have taken this presentation. The presentation is into a narration form. I just put it across into the graphical form because of the easier understanding for my students as well. Secondly, now we all human beings have two different kinds of fat deposits in our body. One is the brown adipose tissue, and second is the white adipose tissue. Whatever the fat we do consume through the diet gets deposited as a white adipose tissue, and maybe some part of this gets converted to the brown adipose tissue. So the brown adipose tissue has some role over to play into the cancer patients, and the white adipose tissue has a lot of role to play into the obese and overweight patients. The overweight patients and obese patients will be having this white adipose tissue in abundance, whereas the cancer patients, even if they are having in those obese or overweight cancer patients, even if they have a lot of white adipose tissue, that gets converted to the brown adipose tissue. In what way this fat conversion has any implications on the cancer patients? Let us see over here. The brown adipose tissues, the one flat globules will have many mitochondria available to convert the fat into the energy. So what happens in a very short period of time, a lot of energy is being converted to produce the heat, that is the thermogenesis, what we saw it into the earlier slide. To keep the patient has a higher body temperature, where the body produces a lot of, the body uses a lot of fat deposits, that is a brown fat I'm talking about, to produce the energy just to maintain the body temperature of a cancer patient. Whereas a healthy patient, healthy person, not a patient, I would say, healthy person without any inflammation, say for example, even an overweight or an obese patient. Of course, obesity is also an inflammatory condition, but unfortunately, the white adipose tissue has only one mitochondria. So it means that it will take a lot of time to actually metabolize this one fat globule. So that is why if you see the fatty people, those who are overweight, if they want to really reduce the weight, they really have to put up a lot of effort in reducing and burning their calories, because every fat globule has only one mitochondria, whereas a cancer patient has so many mitochondria. Even if he is not working out anything, he is not going to do any exercise or any talking or any kind of physical activities, still he will be losing weight, because the heat is just being produced by utilizing the fat deposits in the body, which is converted to the brown adipose tissue. So this is why it does happen, why the adipose tissues does get converted to the brown adipose tissues, because the culprit is over here, the IL-6. So that is why I keep on saying we need to focus on the inflammatory markers rather than the malnutrition, which is the outcome of the inflammation, and it's not the other way around. So that is why to bring down this IL-6 production into the body, we need to give a lot of anti-inflammatory diet, and we should see that we don't, along with that one, we are not giving inflammatory nutrients as well. So if you are going to give inflammatory nutrients and anti-inflammatory nutrients, you are going to contradict your own practice. We all know that cancer patient is a very dismantled situation, and a lot of side effects and disease-induced side effects, and many things which are going to challenge a patient's food intake over here. And of course, we do come across patients who may be having 4 to 5, any of these 4 to 5 side effects. And whenever these side effects are into the peak, we have seen that the food intake reduces almost less than 20 to 10% of the daily adequate requirements. So that's the most dangerous thing what we come across. So we tell the patients before the treatment begins, these are the challenging situations you may come across, and you might exhibit any of these kind of symptoms. But see that whenever you are into a time where you feel you can consume a good amount of food, capitalize on that one, because you never know after 2 hours how you are going to feel, or whether the food will be available to you as well. Because many of the patients, when they visit the hospitals as well, they don't carry any food, and throughout the day they keep starving for themselves. Even if you say that 3 days they had adequate food and the other 4 days they were just compromised and at just 30% of the adequate requirement, it means that throughout the week they never had adequate food in those 7 days. So in any way, if you're going to tell the patients to just give a diet chart and say that you have to follow this chart at any cost, the patient is not going to follow. And obvious that I have to really address these issues, maybe by educating the patient that if you have a diarrhea, what precautions you have to take. If you have a constipation, what your precautions you have to take. If you are anorexic, then which are the things which you will be more appealing to you to accept those foods during anorexic phase. So these are the things which will be educated quite early into the treatment, rather than once the treatment starts and the patient do come to the dietitians after 3 to 4 months or maybe after 3 to 4 cycles of chemotherapy, when a lot of damage is already being done. And we really cannot reverse this malnutrition or the damages which has been caused in the last few weeks in the next 1 or 2 weeks. It's a very lengthy process. So that is why I think these people as early as possible is the most important kind of a thing. As I said, when we are addressing the inflammation, there's no big question to put it across what you are going to use to douse the flame. Of course, that is why we tell that you have to identify which are the inflammatory nutrients which can increase the inflammation. Let us see what are the properties of sugar, which is this is the most controversial kind of a food item which comes into between the oncologist and the dietitians. And let us, because we don't understand why the sugar is bad and why is that WCRF, AICR, everyone is talking about to reduce the sugar content from the diet as far as possible. It is not we are saying or we the dietitians are not saying. It is the international oncology cancer societies which are talking about to bring down the sugars as far as possible into the diet. It's a bad carbohydrate. The carbohydrate itself is a bad, and among that carbohydrate is there are two types of. One is good carbohydrate, the other is a bad carbohydrate. In scientific language, I can say that the simple sugars and the complex sugars. Simple sugars are the ones which are the most damaging ones, and table sugar or jaggery or honey or sabudana or all maida products, they are all of simple sugars. That is why we keep on saying these are the things which you try to reduce as far as possible. You can consume these things only when you are not able to eat anything, because I don't want you to starve as well. But at the same time, I really don't want, being a clinical nutritionist, I don't want to give any nutrient which is harmful for the patient. If I'm a community nutritionist, I would say you eat anything, doesn't matter. I want to keep you happy and say that only when you have a disease, then I will be referring you to a clinical dietitian, then you don't come to me. But we cannot take an approach like a community nutritionist. We are a clinical nutritionist. We have to be very, in just for a small example, I would say a oncologist, a surgeon or doctor or any medical professional will never do any kind of a procedure which will damage the patient and not benefit the patient in any way. It's a very simple thing. No doctor will do any kind of a procedure which will damage the patient's condition and will not benefit in any kind of a outcome. So why should a nutritionist do give any kind of a nutrition which will damage the patient's condition and not benefit the patient in any way? A very simple thing. If it's not a clinical aspect, yes, of course, it's very easy for the dietitians to say, go on eating sugar, doesn't matter. So let me be very strong and very clear over here to clear this factor over here, because many of the forums do keep on people questioning you are wrong in restricting the sugar. Further, as I told earlier, the simple sugars do increase a lot of lactase into the body and they do provide acidic medium. Here, one way we are trying to kill the cancer cells, and the other way through the diet, I'm trying to give an environment, survive them and proliferate and grow over there. So how a dietitian can be a contradictory to the treating doctor? I need to really complement what the doctor is doing and help him that his treatment is being, the patient getting the complete treatment and the outcome will be good and even the survivorship will be a very healthy one. It induces dysbiosis. It is going to kill all your good microbes into your body. Even into the healthy person, if you consume a lot of sugars, 50 grams of sugars throughout the day, you may be taking 30 to 40 grams of sugar in your tea, coffee. The remaining 20-30 of sugars come to your normal diet, what you consume, which you don't see on the table, added sugars. Even if you're eating rice and chapatis and all other vegetables and other things, it will give you approximately 20 to 30 grams of simple sugars. Further, if you are going to add 20 to 30 grams, 60 grams of simple sugars you are going to consume to the daily, you are going to consume. On a normal consumption, I am talking about. There is nothing like added, oh, you had a gulab jamun today or you had a jalebi today, that is why your sugar content has increased. No, I'm not talking about added sweets over here. I'm talking about only the normal conditions every day what I eat. Even every day what I eat with 2 or 3 cups of tea or coffee, I mean all the normally healthy people normally consume around 60 grams of simple sugars. 50 grams of simple sugars does cause the dysbiosis. So we are already exceeding that amount. The research is talking about, I am sorry, I have not mentioned over in the references. The references are available in my other presentations. It reduces the macrophage activity, whereas I want the macrophage activity to be increased over here. I want the immunity to be intact, or I want the immunity to be improved. Why should I give any nutrient which is going to damage the immunity as well? So further, sugar is a very easy fuel for the tumor because it acts like the tumor. The sugar acts like a magnet. The moment the cancer cells sense that there's an increase of blood sugars, the cancer cells will utilize faster than the healthy cells. So it is like we are providing the easy fuel to the cancer cells. It increases inflammation by increasing cytokine productions. It increases serotonin and it induces anorexia. It increases hyperglycemia. Again, hyperglycemia is a condition which into the ICU also, if you see, that is the one thing which every intensivist want to bring down hyperglycemic activities, so that the hyperglycemia is one of the biggest risk factor to induce infection into the ICU as well. Even in normal conditions also, hyperglycemia is ideal condition for the infection to rise and grow. Then there's an increase of recurrence rate and the risking of mitochondrial health. I did mention about the increase of recurrence rate because there are many studies which have come across stating that those patients after the treatment who have stopped eating sugars or have reduced less than 10 to 5% of the total calories, were found to be having a less recurrence rates of cancer compared to the ones who compared to the other group, which were contradictory to the dietary habits of this group. The ones who reduce sugars, they are found to be less recurrences, and the ones who didn't reduce the sugars, the recurrence rate was found to be more among that group. And there is an increase of inflammation as well. And WHO has rightly has defined sugar as the next tobacco. So we need to be understanding that, in fact, if you really see, the sugar is the more culprit than a tobacco. Tobacco, how many people do consume and how many people do consume sugar? Sugar is consumed very almost, I would say, the 80 or 90% of the world population is consuming. Tobacco is consumed by very less, maybe around 2 to 3% of the total population, or maybe 5% of the population. But we are so much obsessed in restricting the tobacco, but we are not worried about the damages done by the sugars. In fact, sugar, this presentation is only for the cancer purpose, so I'm talking about the cancer. But it has every role in every kind of a disease, cardiovascular, renal diseases, or hepatic conditions, every clinical condition, thyroid conditions, everywhere it does a damaging effect to the one. By pharmaco interventions, we do treat the patients, but after the treatment of the patient, if we see when the patient walks into the ICU, how they are, and the patient when he walks out of the ICU, what is the condition of the patient. They never go out of the hospital in a very healthy way. Thereafter, they have to survive and they have to have a healthy life as well. So just by removing sugar and providing some alternative, they're not against the sweets. They are against the kind of carbohydrates which has been given to the concerned person, which is doing a lot of damage to the body. Further, sugar increases blood sugars, it increases insulin, and further the insulin increase also increases the growth factors, the insulin-like growth factors, IGF-1. And what does the IGF-1 does? It increases the cell growth, thus helping the cancer cell to grow and metastasize. We have good references for this one. The most easiest one, the WCRF 2021 report, anyone can refer for that. So sugar in any way is going to help the cancer cells to grow. Then why I should be giving sugar to the patient? Then again, during the arguments, it will be said that does the sugar feeds the cancer? No, the question should not be that one. Whether the sugar feeds the cancer cells, the question should be whether sugar is good for the cancer patient. We need to answer this question rather than who's feeding the cancer cells. Of course, the cancer cells are fed by the sugars, because if there is no carbohydrate, if there is no sugars available, cancer cells will not at all survive. It's a very simple thing. But we really cannot cut down the 100% of carbohydrates from the diet, because it is not advisable. Then we are talking about the keto diet. In keto diet, again, we are going to end up in a different aspect of discussions, which I'm not going to take it into in today's presentation. So there are a lot of things which are coming into the effect whether keto diet should be followed or restricted carbohydrates. What we do is like we follow not even the restricted carbohydrates. We just remove the simple sugars from the diet, and we give adequate amount of carbohydrates, that is a complex carbohydrates, and good amount of proteins. When we are giving good amount of proteins, all micronutrients automatically get followed to the high protein foods. So that is why we should be never be worried about which kind of food has to be given. But if you follow the protein, automatically most of the things does most of the other nutrients that does follow the protein content. I'm talking about the natural foods. I'm not talking about the supplementations over here. Supplementations have a different aspect over here. So any kind of a high protein diet from a natural food, it will be accompanying with all micronutrients. It's so easy to explain and understand and implement. So, and sugar is going to destroy this high protein role over there. So that is why we want that it has to be brought down or it has to be eliminated. So these are a list of the inflammatory and non-inflammatory nutrients. As I said, if you are going to remove the inflammatory nutrients, at the same time you have to also provide the non-inflammatory, that is anti-inflammatory nutrients as well. So one-way traffic is not going to resolve your issues. We have to be seeing the incoming and outgoing kind of nutrients which are going to help and which are going to damage the patient. That is why we see the Mediterranean diet is one diet which is being appreciated all over the world, saying that these are the people who consume Mediterranean diet, cancer incidents are the least among all the population all over the world. And the Mediterranean diet does talk about what did I speak about in the earlier slide. Just lessen all your simple sugars and give good amount of proteins, good amount of complex carbohydrates, and good amount of first-class proteins, what they talk about. And this is what actually we want to practice over here. And that is nothing more than restricting by sugars. We are going to harm the patients. No, it cannot be. It is a skill of the dietitian. The dietitian should know how to complement by restricting the sugars, and if at all the patient does need any sweets, how they can be consumed, at what time they can be consumed, and how it can be incorporated into the diet. So coming to the hematological, the next 10 minutes I'll be focusing on the hemato-oncology. Unfortunately, there is very less work done worldwide on the hematological cancer patients and the nutritional inputs over here. It is seen that only 27% of the hematological patients are being found to be malnourished, comparing to the other solid cancers where it has been seen to 40 to 85% of the patients are malnourished. So we can take a breathing over here saying that my patient happens to be the more healthiest among all other cancer patients. Of course, the bone and soft tissue and other breast cancer tissues, where we see the malnutrition to be not that impactful comparing to the head and neck and the GI one. But hemato-oncological patients, yes, the studies says that 27% of the patients are malnourished. Maybe this is a Western diet, but in Indian conditions, this 27% may be a very less figure. It may be around 30, 35% or 40%, if I'm not wrong. But it may definitely not more than 50%. But we don't have any published data as well. So what we need to do is now, having understood what are the damaging things happening, the first thing what we do is identify these patients, send these patients as early as possible to the nutrition clinic, to the dietitian for an evaluation. Earliest nutrition evaluation gives a lot of space for the nutritionist to act, and because most of the diets are trial and error. You never know which are the things which may work out for a particular kind of a patient. I cannot say everyone to you go on eating only fish and the chicken. And the same way I cannot say everyone to you go on eating paneer and curd. So we need to have a tailor-made food advices for these patients. At the same time, we should be having a general guidance as well. So this is where, if you can identify these patients at the earliest and can refer these patients to the dietitians get an ample amount of time and maybe 1 or 2 follow-ups before the treatment begins, and maybe the patient is in a better condition to come across to the hardships once the treatment starts over there. So how to identify, that's again a question mark. Should I sending all the patients to the nutrition clinic? Again, that's may not be the right thing. What can be advised? For the first time in India, we came out with the nutrition consensus guidelines for the oncology patients for the Indian population. Till now, we never had any kind of nutrition guidelines for cancer patients. Fortunately, some of the well-known names contribute to this this guideline, which was published just 2 to 3 months back. Dr. Arvind Krishnamurthy, Purvesh Parikh sir, and Arnab Goswami, Arnab Gupta, Suman Gupta. These are many people who came and helped the dietitians also to come out with the guidelines, which will be pertaining to the Indian demography and the Indian heterogeneous population, rather than just copy paste what has been established in the Western countries. So if anyone would like to have, I'm going to put it across. This is available in a book form as well, and it's available on the net as well. So this guideline very clearly states that you need to catch these patients early and screen them on the day one or maybe within the 24 hours of registrations, and any patient found to be at risk. And how you are going to define patient to be at risk? The very simple kind of a block, or the gray color block, what I put it, because even if you don't ask these questions, or even if the nurse at the OPD also doesn't ask this question, even if you put this as a poster outside the OPD, the patient can read this and identify himself whether he is at risk of the malnutrition. He himself can guide to the nutrition clinic, rather than you spending time or the nurse spending the time in identifying, asking these questions, and then notifying it and then sending the patient to the nutrition clinic. The questions are so simple. Any patient, maybe you can translate into the regional languages as well. Is there unintentional weight loss in the last 3 to 6 months? You just have to answer yes or no. You don't have to quantify it. The quantification, again, it's going to take time, which the dietitian is going to do the quantification once the comprehensive nutritional assessment will be done. Is there an unintentional reduced food intake? You just have to answer yes or no. Is there a presence of ascites, edema, or water accumulation? That nurse can be done, or maybe even the treating doctor can identify this. Do you have any chronic diseases like diabetes, cardiovascular diseases, hypertension, or any kind of a thing? If the patient answers yes to any one question, we don't have to say that you have to answer 2 yes or you have to answer 3 yeses. Then you will be referred to the dietitian. No. Yes to any one question of this, the patient should be sent to the dietitian. It's so simple. So yes, of course, the serum albumin and CRP values, CRPs are not done to all the patients at any centers. Serum albumin, if it is available, if they are hypalbuminic, yes, immediately they can be sent to the nutrition clinic. And what we need to do, the guidelines are very clear: 25 to 30 kilocalories and 1.2 to 1.5 grams of protein. Indian population is a protein deprived population, a very big challenge again. Normally we consume around 0.7 to 0.8 gram. Now you see the recommendation is 1.2. That is almost 50% increase than what they're consuming. So you can just imagine what is the challenge in front of the dietitian, and that dietitian is going to deal with the anorexic patient and an inflammatory patient, and we need to provide at least 25 to 30 kilocalories per body kg weight per day, and at the same time 1.2 grams of protein. But having said that, if we keep on following the calories, we will fail into addressing the protein issues. So I keep on saying, just concentrate on the required protein. The calories are automatically going to follow. But if you are going to focus on the calories, the chances that you may not meet the adequate amount of proteins. How it can be done? But for that, you need to understand what is the weight of the patient and what is the requirement of the patient, what is the inflammatory condition, and if at all any comorbidities are there, then you will be addressing the issue whether it has to be 1.2 to 1.3 or 1.5. We do even give more than 1.5. We do go till 1.8 and 1.9 if the patient has ascites, edema grade 2 or grade 3 as well. So we go beyond this range as well. So that is why a complete nutritional evaluation does give a clear picture saying that how much of calories. This is actually hypocaloric. It is not high caloric. High caloric will be something around 35 to 40 kilocalories. So the guidelines say that you have to give a hypocaloric and high protein. So that is where we need to really balance between when I'm going to recommend diet to the patients. But I want to reduce the calories because the guidelines are saying that you have to do hypocaloric. That is just the adequate amount of calories. I need to remove all the bad calories from the diet, not the good calories. And what are the bad calories? I did mention about the bad calories, about the sugar, jaggery, honey, and sapotanate, maida things. These are the bad calories which I don't want the patient to be consuming and complicating the metabolism into his body. Further, we need to take the help of the multidisciplinary team. But in hemato-oncology, I don't think that there's a robust role of MDT team over here. But in solid cancers, the speech swallowing therapist, or maybe a patient who is deprived, is in depression, a psychologist, or maybe a occupational therapist if the trismus is existing. But fortunately, in hematology, we don't have to have a bigger role of MDT over in this area. These are complications we all know. These are the complications what we come across, and any kind of dietary intervention, as I said, there is no specific kind of intervention. It's all trial and error. What may work for the one patient may not work for the other patient as well. But yes, we need to identify these symptoms as early as possible, and we have to be aggressive in addressing through the multidisciplinary approach. If at all any modification of the diet is required, either the texture has to be changed, or the viscosity has to be changed, or maybe the calorific density has to be changed. So these are the things, yes, some of the guidelines which have come. This is the ITSI framework, which is a California-based one, which recommended a different type of a texture. But when we analyze this one, it's too complicated to understand to an Indian scenario. So we came out with our own kind of recommendations to the Indian population with just the 6 consistencies, which does address with all kind of a dysphagia complications. It may be a very thin liquid, it may be a thick liquid, or it may be a very thick liquid, or a pureed, or a soft mist, or a normal. There's the overcooked ones. So speech evaluation normally helps us in identifying which kind of consistency of the food should be recommended. After his evaluation, we stick to that particular kind of a dysphagia diet. Some of the equipment which are required, but for this presentation, they are not needed. There's a compliance problem. Patients, we do plan a very good diet, but we find that the patient hardly consumes around 50 to 60%. All those complications, what we spoke earlier, are the culprits over there. Why my compliance to this patient goes on poor even after counseling the patient and trying to make the patient educative about nutrition, but we keep on failing. Then we have some of the tips over here where we can really slightly try to work it out. We tell the patient, try to use your 24 hours to feed yourself, just not morning from 8 to evening 8 or 10 o'clock. So if you are not able to eat in this period of time, even in the middle of the night, if you get up and go to visit the washroom once in a night, you can keep a feed ready with you, and immediately you can drink that feed. It doesn't matter, at least some nutrient you can compensate. So this is how we tell them. And also we tell them to catch up the feeds. If you have missed out on any one of the feeds, and in the next feed, if you can try to consume more of the feed, compensating the missed out feeds, try for that one as well. And every feed is important. We tell them, if my plan is of 7 feeds or 8 feeds, it doesn't mean it is 5 feeds or 6 feeds are sufficient for you. So when we tell them at any cost within 24 hours, all these feeds have to be completed at any cost. Even if you are visiting the hospital, carry all your foods, and you don't have to hesitate. If you are waiting for the doctor's appointment, don't compromise on your food consumption. At any time, when the time is up, you make your feeds, and maybe you can start eating it, or maybe you can have a health drink in the form of any oral nutrition supplement, and you can consume. And standardized nutrient density, equalized calorific values. This is the dietitian has to take a call on that one, because if the patient says, I took only 3 feeds. Now, do you know what those 3 feeds calorific the strength was there? Were there all those 3 feeds what he consumed was high in calorie or high in protein, or they were high in calorie and protein, or maybe he has missed out on micronutrients? So you don't know if the patient is missing out on any 1 or 2 feeds, which are the feeds which were nutrient dense, which he has missed out on. So that is why I keep on saying to my own team as well, you have to equalize the feed. And if you have an equal feed, say for example, all feeds are going to give you 300 calories and around 10 grams of protein. So of course, a 10% of deviation will be that depending upon whatever they are going to consume. If the patient says, no, I am taking only 6 feeds and skipping out on 2 feeds, I'm very much clear the deficit is of 600 calories and 20 grams of protein. Now I have to think about how I can compensate those only 600 calories and 20 grams of protein, rather than I've been pre-working on the diet chart. Of course, when we plan the diet chart, the patient's consent and their affordability and their logistical availability are also being taken into account. So that is why standardizing the daily feeds are more important while planning a diet. Just by giving just your breakfast, lunch, and dinner, and that's over. You can have 2 biscuits over. So that cannot be done over. Then avoid missing feeds when visiting hospitals. I didn't mention about that one. This is the one thing where we want to know how a nutritional supplementation is done. First, we need to understand all nutritional supplements have different strength and weaknesses. Some are giving very high protein, say around 40 grams of protein, and very less calories of around 35 to 40 or maybe 100 kilocalories. Some are giving you around 10 grams of protein and 200 kilocalories. Some are giving omega-3 and some are not giving omega-3. Some are giving non-vegetarian omega-3 and some are giving vegetarian omega-3. Some are giving you good amount of MCTs. Some supplements are not giving any of the MCTs. Some are fiber rich, some are not fiber rich. Some are fructooligosaccharides rich, some are not having any fructooligosaccharides. So these are the things which determine while recommending a nutritional supplementation. There are many studies which indicate that random supplementation has done more harm to the patients than non-supplementation. We need to take care over here. Random supplementation is not the way to address the nutrition intervention to any patients. They have to be evaluated and has to be assessed what is the shortcoming and which are those days which are the shortcomings, and which is the time of the day which they normally skip off the feeds, and when and how much has to be supplemented. So it happens to be a very calculative kind of a thing where a lot of things are taken into the consideration when we come across stating that this is a supplementation you have to take, and in these many doses or these many scoops you have to supplement yourself. And those days which are going to have a good food intake, then how much you can reduce, and the days when you are going to eat much less than what you are reporting as of now, how much you should be increasing. And do you have any other comorbidities like diabetes, renal functions issues, or even hepatic issues or cardiovascular diseases? Again, these are the things which are going to dominate the supplement selection. So random supplementation, we will do more harm to the patients. And if at all any supplementation has to be done, it has to be done only after proper evaluation. These are all dietary guidelines for the patients, like hygiene maintenance. They have to keep themselves very clean. They have to be physically active. The food should be warm while eating. Nothing stale should be consumed. Nothing added colors and flavors should be consumed. Nothing from roadside, hotel, canteen, and where the food is being handled by many people, that should be avoided. So all these things we do tell them patients to protect them from the infection incidents. These are some of the same thing what I said. Even all those kind of cold drinks, or maybe the maida products, the bakery products, or anything which will be cooked and kept in the freezer, and the next day and next days also it can be utilized. Such things should be avoided. Pickles, noodles, kurkures, anything which has been preserved should be avoided. Maida biscuits should be avoided, and a good amount of dry fruits they can consume. Again, when you are telling them to include good amount of dry fruits, which are the dry fruits are allowed, and how much of calories it is going to contribute to the patient. And if the patient is overweight or obese, again the dry fruits cannot be given. So all these things has to be taken into consideration while giving selective kind of recommendations and a selective kind of a supplementation as well. These are the relatives. When we are talking about the patient hygiene and everything, the relatives have to be also hygienic, and they have to handle all the equipment and the food items in a very healthy way, and they have to be cleaning in a proper way, and what's the right way to cook the foods, and how it has to be served, and what the care has to be taken if the patient is having any kind of symptoms, and what are the right times to serve. And if the patient is not ready to eat the food, they should not be bringing the food and taking it for 1 hour, and thereafter again the patient will be eating the food. Once the food temperature falls below 67 degrees, again the microorganisms do start increasing. So we need to educate the patient's attendant along with the patient as well. TLS is one of the areas where you all are aware of it. But just to mention that we don't have much role over here, because by the time TLS is being identified and a dietitian does come and try to recommend a diet, the pharmacotherapy actually takes care of it. Of course, you all know TLS is better handled if it is being identified as early as possible, and if it is prevented, the prevention is the best aspect. And I'm not the best person to really talk about on this one, as you all are handling these cases. So it's I leave it to you for this kind of information. Of course, as I said, there are not much evidences available throughout the world to handle TLS through the nutrition aspect as well. So there are symptoms, and we will be handling more of the symptoms rather than the actually the TLS impact into the body circulations. So that we are not actually of concern over here. We will see whether the patient is nauseatic, or the patient is not having a good appetite, or patient is having some kind of muscle cramps. So these are the things what we will take in signs and symptoms, and we will try to work it out on that factor as well. As I said, the best treatment is to prevent prevention is the best treatment. And of course, hydration is one of the things which is the best intervention to prevent TLS. Of course, the correction of electrolytes and other things. As you all know, I don't want to really speak on this matter, I think so. Because there is one study which did speak about reducing potassium and phosphorus from the diet. But let me tell you, all high protein are rich in phosphorus. So if you want to reduce phosphorus, you're going to reduce the protein. So we don't have really clear guidelines either from the studies or from the any societies, whether you really have to give a reduce potassium and phosphorus from the diet during the TLS flare. If we are going to do that, we are going to reduce good amount of proteins over there. So very tricky situation. Should I reduce the protein? By doing that, I'll be underfeeding the patient. In any way, the patient is compromised situation, and further I'll be contributing to the malnutrition and will not be improving the nutritional status by reducing the protein content. So I think we both have to come out and discuss this one. the treating doctors and the dietitians, maybe we should have some guidelines on this one in the lines of what we earlier published for general cancer patients. We should have a hematological cancer guidelines, and dietitians and the hematological oncologists can come together and look out for how these areas can be addressed over here. Probiotics is a controversial. There are no clear guidelines or no clear studies whether probiotics should be recommended. Of course, the normal cancer, hematological cancers, it's okay, but hematological patients undergoing BMT, it is being contraindicated. They are not advised to be recommending probiotics when they are into the active treatment. Again, over here during this last 2-3 slides, now I'll be just finishing. Then again, during GVHD, again, whether to feed the patient, not to feed the patient. Again, how far the diarrhea is severe. These are the things which we really cannot have a direct answers for this one. And the most easiest is just go for the TPN infusion, stop feeding the patient. Because to feed or not to feed is a totally both controversial. So some are saying slow enteral nutrition is beneficial. Some are saying total stopping of the feed is the best way to go about. Some say TPN is the only way out. So again, I would say that we need to come together and really discuss under what conditions enteral nutrition can be permitted. If at all permitted, how far it can be permitted. Just maybe around 500 ml or maybe 1000 ml. Tropical feeds is permissible or not. So these things, I think we need to come out and discuss about these things. Sinusoidal obstruction syndrome, again, same things over here. We don't have any studies, no guidelines over here, but looking at the ascites and food retention, we plan the diet, we reduce the sodium, we reduce the fluid over there. And if it is a jaundice, a prolonged jaundice, or just active phase of elevated bilirubin, we don't restrict fats. But if it's a chronic status, yes, we ask for them to reduce fat and give good amount of MCTs. As the patient is underweight and whether the patient is obese, again, the MCT recommendations do differ over here. So should I be providing any calories through MCTs or not? And again, it comes as a question mark over here. And in certain cases where the liver impairment can be occurrence, which we suspect it can be happen because the patient is on a parenteral nutrition for a prolonged period of time, then there are chances that the cholestasis can set in and more liver deformities can happen, and the situation might actually grow worse. So these are the things, again, we need to take an early call on this one, whether we should restrict the fat, and if at all after fat restriction in any other form fat can be given, if yes, and how much has to be given. And yes, of course, the manganese restriction is being recommended for this one by just 1 or 2 studies, not more than that. Though, if at all manganese restriction has to be done, these are the just 4 or 5 food items which are rich in manganese. But in any way, all these 3-4 items are not being so commonly consumed, except for banana, I would say. Spinach once in a while that the patient will consume. Tick is also once in a while. Pineapple is again rarely being consumed. So rather than going for any kind of a restriction, I think a pharmacological nutritional intervention will be more helpful rather than a proper nutritional intervention. Maybe we can give a handout to these patients whenever such kind of a situation comes. We can just say that these the food items are not supplied to the patient. Glutamine has been seen in just few studies that yes, the glutamine infusion may protect liver. This is what they say. However, the glutamine is really beneficial. Again, it comes into the controversy. As I said, there are no clear guidelines. There are no big good studies available to us. We are not in a position to really take a very good call on that, whether the random glutamine supplementation has to be done, or again, as I said in the earlier, more or less all these interventions are trial and error kind of a thing. Some patients may benefit, some patients may not benefit. And how to identify this patient who can be benefiting, it's a very tall call to make a comment from my end. And these are some of the recommendations from the IAPN guidelines for the Indian population, what I recommended. You can go through the websites. Nothing more I can add. I already did mention about all these things quite early in my presentations. These are some of the symptoms where the dietitians will look after if at all diarrhea is there or constipation is there. Whether to give a good amount of soluble fibers, or I just have to give good amount of probiotics, or maybe I just stop feeds for few days. These are all, again, as I said, trial and error. Ketogenic diet, again, I said it depends upon the treating doctor. They have to give free and to the dietitian, if at all, if they believe in ketogenic diet. Because the compliance of ketogenic diet is a very challenging one. And if at all it has to be done, it has to be done under a very proper observation of the treating doctor as well as in the dietitian. And the patient has to be a very good compliant, very well good counseling has to be done, and why it has to be done, he has to be explained nicely, because his cooperation is very much important, because it's a very tough to follow ketogenic diet. Maybe 1 or 2 days or maybe 3-4 days they may follow, but for continuously for 3-4 weeks or 1 week, it becomes a very 1 month, it becomes a very tough call for the patient to be on a ketogenic diet. These are some of the drug and nutrient interactions, but most of the things normally, anyway, we don't drink grapefruit. No patient, even if they demand, they will not get, unless the patient is a very rich person and it's very easily available. We can tell them to just to avoid grape juice. Alcohol, most of the patients do avoid alcohol at that time. There are certain like Kamycin, which is seen to be interacting with calcium and vitamin D supplementation. Yes, of course, if supplementation, normally the dietitians don't do the single nutrients. So the call goes to you all whether the calcium vitamin D supplementation is being taken a call on that or not. If the patient is on a Kamycin. Like that, there are some certain things like nitonib, where it means that high fat food normally reduces the impact of nilotinib. So we tell the patients to be on a moderate fat diet. And in fact, there are some guidelines do talk about when you want to increase the calories, don't increase the carbohydrates, but increase the fat content in that. But when you increase the fat content, which kind of fat content? Again, as I said, good carbs and bad carbs. Same way, there are good fats and bad fats. So we need to say that the good fats are being recommended like omega-3 fatty acids rather than the omega-6 fatty acids. These are again, there are many anti-cancer diets are into the circulation. Any patient, however the patient may be, he or she will be doing a lot of research even after we counsel them, and come out with a lot of myths and kind of fancy diets which claim to be curing the cancer and killing the cancer cells. So these are not true things. So we need to be very moderate enough to consider that the reality is what kind of a anti-inflammatory diet can work. Just stick to that one. We need to feed adequately. Don't change the diet too much from the patient's dietary habits. But certain alterations are required, which are of a healthy in nature. This is a very recently published book. All those questions which are not answered, maybe you might be having many other questions as well. We will try to address some of them during our discussions. But all these questions you will find a very good book. As I told you all, there are more than 55 people have contributed, comprising of oncologists and onco-nutritionists. I'm specifically saying the onco-nutritionists have contributed to that one. It's very cheap and it's available on Meesho. I'm going to share the link as well. If at all, you can ask for any other companies. The companies have already have extra copies. You can take it from free copies are also available. So anyone who is interested, even from Amazon, but Amazon has some linking problems over there. So anyone interested, they can either contact me or contact the Dr. Reddy's, or you can buy it directly from Meesho's link, which I'll be sharing very soon. Thank you, and I will be happy to address if you have any questions regarding this.
Thank you, Mr. Shiv Shankar, for that wonderful, complete coverage of this a bit complicated subject for a clinician. Lot of learning, many things which we did not know, and you made it very simple. Before we proceed further, I invite now Dr. Reddy's lab, that is Dr. B.S. Saurabh, to speak about what is Salivia max.
Yes. So I'll share my screen.
Sure.
Sir, can you please confirm? Is my screen visible to you?
Yes. Yes.
Yeah. Thanks a lot, sir. Thank you, Agrawal sir, and all for giving this opportunity. Sir, I would like to take you through the science behind the Salivia max. So, If you see on right side of corner, so there is a Dr. Reddy's Nutrition Academy. So Dr. Reddy's actually it has a own nutritional setup, means a laboratory where we have R&D and even the nutritionist scientists and all. They are working on these products, and it is an in-house. These products are coming from Dr. Reddy's house only, so it is an in-house product. So I would like to take you through this product now. So before going ahead, I would like to tell you just about Celevida. Celevida is a made up of two different words, that is celebration and vida means life, celebration of life. So as the name is there, so with we actually find out the therapy gaps, or we can say the nutrition gap, and we actually try to serve better in that shape. So as everyone knows, the Dr. Reddy's is known for the pharma very well, and now since last 3 years we are in nutrition, and this is our second product. This is our first product actually we have introduced to the market, and subsequently we are launching other products as well under the umbrella of Celevida, like DLS for dialysis, Live for liver. So now I'll take you through this product, Celevida Max, which is for the cancer patients. So if you see the even Shiv Shankar sir said that means the compliance is the very common issue with this. So the several reviews and meta-analysis studies has clearly shown that means dietary counseling and even the oral nutrition supplements means patient has a very poor compliance with this. So another study, there is a Baldwin et al. Study clearly shows that patients has a very less compliance to the ONS as well as for the dietary counselings. Only 19% of subjects has taken a prescribed oral nutrition supplement throughout the period. So, and what is the major challenge over here? That the major challenge is that means they have to take a at least 8 to 10 serves of powder, scoop of powder, which is very huge, and patient usually deny to take after a couple of days or after certain days. So even the guidelines has clearly says that 1.2 to 1.5 gram of protein per kg per day is required. If you take the example of the 60 kg man or a lady, so definitely he or she requires 72 to 90 gram of protein per day. And another thing is that our Indian diet is actually deficient in protein, and Dr. Reddy's has identified this gap, and we started working on that, and we have developed oral nutrition supplement over here. And the main, as I said in previous slide, means the main challenge is that the patient has to take a very huge amount of powder, that is 8 to 9 scoop, that comes around 54 to 75 gram of powder, and this powder only delivers 15 gram of protein. So if you see the innovation from our end, it is a 33 gram of sachet, and it delivers a 16 gram of protein from that. And most important thing is that we have isolate, whey protein isolate and soya protein isolate. Isolate is the purest form of the protein, most purest form, which actually helps for muscle gain. So as I said, means the isolate are the purest form, because quality of protein is equally important. So in this 16 gram of protein, 60% of protein is coming from the whey protein isolate, which is quickly absorbed, means 8 to 10 gram get absorbed per hour, and 40% of protein coming from the soya protein. So it's a mixed blend of these two different protein. One is the faster acting and another one is the intermediate acting protein. So which actually helps in the muscle protein synthesis. So as I said, means why protein isolate only, why we have used it? Because there are certain products, they are using whey concentrate and all. So we are in the whey isolate category. It's a purest form, which has a 90 plus percent of protein, and even it has a less lactose and milk fat compared to the whey concentrate and whey powder. These three are the actual different type of protein: whey powder, concentrate, and isolate. The isolate is the most purest form. And also isolate is the rich source of the branch and amino acids. So there are some studies has done, and they have clearly shows that means whey protein isolate supplementation to the cancer patient will give which helps in a body weight as well as the muscle strength. So if you see here the 166 malnourished advanced cancer patients, they have enrolled in these studies, and the two different groups they have made. The one is taking a nutritional counseling along with the whey protein isolate supplementation, and other is not on WPI, that is whey protein isolate. So if you see the result over here, it clearly says that means WPI supplementation improves the fat-free body mass index as well as body weight and muscle strength. One more highlight I would like to give here: we are also doing study on our innovation on our product, that is Celavida Max. So this is the interim result actually. We did because the study is ongoing and this will take a few more months to complete. So currently only 30 patients have enrolled and study is ongoing. So we receive a 1 month data. They have consumed 1 month supplementation over here. So this study is a multi-centric open label single arm study. So evaluation of pre-albumin and albumin means we have seen the pre-albumin and albumin level over here. So if you see over here, the 30-day supplementation with Celavida Max means 2 sachets per day, means 32 gram of protein will be delivered here. And if you see in the table, it clearly says that serum albumin and pre-albumin level were maintained quite well. Once the cancer progresses, definitely serum albumin level drops. But in over here, actually, the protein level is quite maintained well. So there are still more data we will get in upcoming months, and even the sample size will be huge. That is 100 plus sample sizes there. So it will take another 6 to 7 months to complete this study, and once it comes, definitely will come back to you. So another important aspect is that the medium chain triglyceride MCT we have added over here, that is a 15 gram per 100 gram of this powder. So as everyone knows, this is a fuel for the patients. Everyone means it quickly get absorbs into the body and metabolized to the energy, and it doesn't require the bile salts for digestion. Another aspect is that there means no added sugar. Even Shiv Shankar said that means sugar is another threat over here. So in our product, we have not added any sugar. Even the American Cancer Society clearly said that limiting the consumption of product with added sugar is recommended. So next one is the astaxanthin. Astaxanthin is very potent and very strong anti-inflammatory and antioxidant. It has an antioxidant property, and it is also we have this is coming from the wheat source only, that is algae. So if you see here, it has a two major benefits. That is the it has anti-inflammatory action as well as the immune boosting action. So this some studies has also done on this, and it clearly shows that 3 months a long human study shows that means supplementation of astaxanthin reduces the TNF alpha by 43%. So as well as the astaxanthin downregulates the expression of inflammatory mediators like IL-1, 6, 8, and TNF alpha. And the second benefit is that the immune boosting action, that is, it improves the T cells and B cells, as well as improves the concentration of salivary immunoglobulin A. The other key aspects or key features of product is that this product is high in omega-3 fatty acid. It has a fiber as well, that is fructooligosaccharides, and all essential vitamins and minerals. So all the ingredients, including omega-3 and astaxanthins, are coming from the vegetables. And most important thing is that mainly in cancer patient, dysgeusia or change in taste or altering change is very commonly seen. So that's why we have came with a very different flavor, that is the orange flavor. These are the tangy flavors. So people, because vanillas and chocolates are very common and patients are getting bored, so that's why we have come up with these tangy flavors like orange and strawberry flavor. So thanks a lot, sir. So I'll be happy to take questions if any.
Thank you, Dr. Saurabh, and of course, thanks, Shivashankar. Before we come to the Q&A session from our faculty here and the audience, we will just give the answer and the winner's name for the quiz. So I'll just share my screen. The quiz that was put today was related to acquired pure red cell aplasia. You were given a case profile who has received a variety of treatment, and you were asked what other treatment did help him short of bone marrow transplantation. He had already received cyclosporine, corticosteroids, rituximab, gamma globulin, mycophenolate, azathioprine, cyclophosphamide, methotrexate, danogen, and even ATG, and was referred for transplant. So that was the question. These are the answers that we received. We received answers from our, mind you, this was not just meant for students. If I said this is for PG students, I said PG students and others. So it's open to everybody. All our quiz are open to everybody. So answers we received was, the commonest answer we received was alemtuzumab. And then we received the answer thymectomy. Of course, this patient thymoma was ruled out. Daratumumab, luspatercept, which improves hemoglobin in MDS and thalassemia. Pyridoxine, which works in some of the pyridoxine-dependent anemias. Roxadustat, nephrologist friend. Erythropoietin. In PRCA, usually erythropoietin is sky high. Plasmapheresis, a transient treatment for antibodies. Bortezomib, which makes some sense because you are taking the plasma cells, and immunoglobulin, but that was already tried. So these were not the answers we were really looking for. This is just a slide to tell you what the algorithm for treatment of pure red cell aplasia is. So diagnostic workup is you exclude genetic pure red cell aplasia, look for parvovirus B19 infection, give them specific treatment, look for thymoma. If it's there, do thymectomy. So once all that is ruled out, the treatment is cyclosporine. Cyclosporine is extremely effective, works in about 75% of patients, and with or without corticosteroids that can further enhance its activity. And if there is a response, then you try to maintain it. And if these things have failed, then there is cyclophosphamide with or without corticosteroids. Our patient had tried all this. And then you have, if there is a LGL, then alemtuzumab, ATG. If there is MGUS, then bortezomib. If there is hypogammaglobulinemia, replace that. If there is B-cell proliferation, rituximab, etc. So various kind of treatments have been employed, and this algorithm has been published in Blood about 2 years ago. The drug that we were looking for was sirolimus, which was previously known as rapamycin, and it was called rapamycin. These are mTOR inhibitor. It was called rapamycin because it was first isolated from the soil in an island called Rapa Nu, which is an eastern island. So rapamycin is same as sirolimus, and these are mTOR inhibitors. We use various mTOR inhibitors in hematology and oncology. Here we are talking about sirolimus, which has been reported to be effective and well tolerated in many immune-mediated cytopenias. Classical example is autoimmune lymphoproliferative syndrome, immune thrombocytopenia, and Evans. The dose is 2 milligram on the first day and 1 milligram daily, and you should continue it for minimum of 6 months before discarding it. This is a publication. Sirolimus is effective for relapsed refractory intolerant acquired PRCA, single institution. The patients who had no response or could not tolerate cyclosporine, these patients were given 6 months, they had received 6 months of cyclosporine already with or without steroid, and then were treated with sirolimus for at least 6 months. 64 patients were enrolled, and look at the results. The response rates after 3, 6, and 12 months were 60%, 80%, and 74%. And the complete response rates were 50%, 65%, and 66%. The median follow-up was 14 months, and 8 out of 54 patients relapsed. Apart from hemoglobin improvement, it led to decrease in the creatinine level and the ferritin level. Adverse events were recorded in 19 patients. Secondary acquired puerperal dysplasia with stable underlying disease had similar results as that of primary acquired puerperal dysplasia. In summary, sirolimus is effective in patients who have refractory, recurrent, or intolerant acquired PRCA with low rate of toxicity and low rate of recurrence. There's another publication, successful treatment of acquired puerperal dysplasia with sirolimus, where 21 patients were enrolled. Response rate was 76% with 42% complete response, and this was achieved in 4 months. And side effects included infections, mild oral mucositis, sinus tachycardia, rise in creatinine, transaminase, triglyceride, cholesterol, and thrombocytopenia. Most of the patients stayed in remission for a long period. Early withdrawal of drug can lead to quick relapses. That's in frontier and oncology, role of mTOR inhibitors in hematological diseases from bench to bedside. So correct answer we were looking was sirolimus. Well, the second, we got only 2 correct answers. The second in the time period was by Dr. Amit Khurana at 11:45 a.m. And the fastest finger fast was once again Dr. Gopinathan. So Dr. Gopinathan has developed a habit of winning the quiz. This was at 11:39 a.m. As you know, his DM clinical hematology at SGPGI Lucknow. So Dr. Gopinathan, again, congratulations for again winning the hematology quiz. Well, that's it. And we'll now go through the Q&A session. And are there anybody interested in asking question? Please raise your hand. So Upendra Sharma, yes.
Thank you, Dr. Mishra, for taking this undiscussed topic for today's webinar. Thanks, Dr. Shivshankar, for presentation. So, can I ask a question to Dr. Shivshankar? So, what is the role of gut rest in patients of mucositis? Whether we have any role of gut rest for patients of mucositis?
Role of what you said, I couldn't get it.
Role of gut rest. So, NBM for patients. Yes, NBM for patients of mucositis. At
any time, at no point of time, nutrition restriction has been recommended, unless until GVHD, where the diarrhea of a higher grade is being prevalent, where we need to give the rest. But during mucositis, the oral mucositis, so we don't have to. But intestinal mucositis, yes, we need to shift to TPN and give some rest for maybe till it subsides. So it depends upon that.
Can I ask another question?
Yes, please.
We will come back to you. What we'll do, we'll have one question from one faculty and we'll come back to second, third, fourth round. Dr. Parthiv Mehta. Unmute yourself, Parthiv.
Patient of hematological malignancy on chemotherapy, does it require a stringent control of sugar or it should be liberal control? It is around 140 to 180.
Unfortunately, we don't have a quantifying measures. Like maybe if we have a CRP values or any other inflammatory markers which can guide us, like, so we have to rely on the symptoms exhibited by the patient. And symptoms may not be the right way to actually follow them. It may be non-inflammatory symptoms also can, say for example, 1 or 2 episodes of vomiting may not be actually an inflammation. It may be just a acute phase of some kind of a side effects of the kind of a thing. The restriction of sugar is more or less has to do with the entire lifestyle rather than only for the treatment as well. So if it is more of an education to the patient why sugar is bad, rather than thinking about during the treatment, I need to restrict the sugars and how far I have to restrict. For a healthy person, the American Dietetic Association does recommend that less than 10% of total calories. If less than 10% of total calories is normally, if you consider 2000 calories, it will be 200 calories of that one, which comprises of 50 grams of sugar. But that is for the healthy person, but there are no recommendations for the cancer patients. WCRF, AICR, what they say is it does reduce added sugar to any of the feeds. In fact, they went ahead in stating that you need to restrict even added sugar to the tea and coffee. So now you can take a clue from that one, how far I can restrict. So even now also we don't say 100% restriction, we say you minimize as far as possible. And for tea and coffee, you can just use a minimal kind of a thing. Secondly, we have other alternatives like stevia and monk fruit sugars, and other alternatives are there. Even all alternative sugar substitutes are permitted now. Earlier, which were seen to be carcinogenic, now they have been relieved from the list of banned items. So even they can be used in a free way. So when we have the alternatives available, better to go for the healthier ones rather than following the sugars into your diet.
Thank you. Dr. Kripa Bajaj, one question from you.
Yes, sir. Thank you, Mr. Shivashankar. I learned today a lot regarding nutrition. I have one question. Cancer patients with comorbidities like renal failure or prior liver diseases, what modification is suggested? Because there is a lot of contrary data is there regarding high protein supplementation in both of the patients.
Very tricky situation. I'll tell you, none of the guidelines talks about the renal insufficiency during the cancer treatment, as far as the nutritional interventions are being considered. In AKI, whenever it occurs, like there are two different guidelines talking about 0.8 grams of protein and one is talking about 1.2 grams of protein. Both are totally contradictory. But in our conditions, we normally what we do is we stick to around 1 to 1.2 grams of protein and observe the progression of it. If the creatinine still goes on increasing, then we go on reducing the protein content from the diet. So to make a general statement, it's a very difficult, as we don't have any data for that one to make a strong statement over here. Having said that, following the patient's prognosis along with the dietary intervention, that is the best way what we can follow. The dietitian can always follow the renal function test, how they are progressing, and maybe the treating doctor also can keep on making a comment over there if we need to be cautious with the diet or not. I really don't know how far a nephrologist would be helpful to us, because we are more close to the nephrologist to work on the protein allowances to be permitted. But we are not the same confidence we don't enjoy with the hematological treating doctors. So we need to bridge a gap over there and try to come out with an understanding if a AKI induced by some chemo drug, should we restrict a protein or not? Because and how far this AKI is going to be subsetting. If it's just going to be a 3 to 4 days or maybe 1 week, I don't think there's a restriction which is required. But if it is going to compound a problem of a forthcoming any kind of an event, then we have to be very cautious. So that's why I said it's a very tricky situation.
Yeah, sir. Underlying CKD patients, nephro-HP, different formulations we do see. So when we go through the data, there's a lot of controversies out there. So I just got wondered like what is the correct?
Madam, CKD is very clear. We need to restrict the proteins. There is no controversies whether to increase the protein or not. So you need to maybe if the serum creatinine is around 5.5 or 6, we will go down beyond 0.6 and below. But if it is around 0.2 and 0.3, 3.1 and between 3 to 4, we would stick to around 0.8 grams of protein. That's fine. So that's okay, I think.
Thank you.
We'll move on now. Dr. Smita Kaya.
Yes, sir. Thank you so much for this educative talk. I have one question on what is the role of gut microbiome in deciding all this nutrition intervention in patients of malignancies and hematological malignancies.
Madam, first of all, thank you for asking this question, because we always we never think about the gut microbiome, even though it's an upcoming area. But we take it very casually. And this is the one area which is going to determine in the near future, even the treatment will be related to the gut microbiome. And unfortunately, gut microbiome cannot be developed in the next 2-3 days by giving some kind of good prebiotics and probiotics. And we can think about, okay, the gut microbiome is improved. So it's a continuous process of a inbuilt kind of a health of it is just like immunity. You cannot build an immunity overnight or maybe 2-3 days or 1 week. So what kind of food the person is continuously consuming. But at the same time, I want to preserve whatever the microbiome is there. So I don't want to give anything which will harm that one. So that's why I kept on saying that the sugars are the things which are going to destroy your microbiome. Why anyone would like to bring down the immunity of the patient who is already at the danger of compromised immunity. Such a wrong kind of an intervention, if I give a free hand to the patient, okay, you can eat anything. Or you just don't follow, you just see that you feed yourself something. So we need to draw a line between feeding and nourishing. So feeding is very easy for us, but nourishing is, yes, of course, a tough one. But restrictions overrule at the time of starvation. If the patient is starving and not able to eat anything, then I don't keep on telling, oh, you don't have to eat an ice cream or you don't have to drink a fruit juice. That time the feeding is more important because your survival is more important at that time. So my priority is to see whether to make the patient survive or make the patient nutritious, healthy, and face the treatment and complete the treatment in a healthy way and have a very really quality of life further to that one. So your goal has a lot of thing over there to when you start counseling the patient, because you need to say, is it an acute phase of microbiome you're talking about, or you're going to talk about your remaining life. So that's right. In any way, all this information is going to be having an impact on the gut microbiome. So my role will be to give good amount of oligosaccharides or prebiotics, probiotics, as and when it is possible for me, and preserve and maybe improve thereafter. Yes, it's very much important. Positively, yes, for that.
Thank you, sir.
Thank you, Dr. Akanksha.
Yeah, thank you, sir, for a very comprehensive talk, and it was really an eye-opener to me. My question is that what is your take on the use of appetite stimulants? And now there is this IV vitamin therapy which is recently discussed about. So do you think they have any role in these cancer patients with the undernutrition?
It's a very, again, a controversial area, and none of the studies do confirm that by giving appetizers or the appetite stimulants, the patients have built up muscle mass. All the interventions have seen that there was only weight gain was there, but because of the fat deposits and not by the building of the muscle mass. So that is why we need to be really understanding what kind of weight gain we are desiring for. Is it just the weight gain, or it is the right kind of a body composition of what we desire for? So having that anamalerin, something of a this-natured drug, which was recently being tried on lung cancers, has shown some promise in muscle buildup. But it's not yet available in India. They're just waiting for that. But they have not tried in any other cancers as well. So we need to wait and see in gastrointestinal cancers, how do they fare up? So it's too early to comment, but whatever the available ones are there, they're not actually being recommended in TMH, and we don't even ever refer to that one. But you did mention about some vitamin supplementation. I'm really not aware of it. If you can just make a comment on that for my education.
Actually, recently I came across some articles where they have used high-dose vitamin C therapy, just as a using concomitantly with chemotherapy, not for any therapeutic purpose, but just to improve the chemotherapeutic agent efficacy. Yeah.
Very difficult to make a comment on that. Need to study on that. Yeah.
Thank you, Dr. Siddharth Shankar Ray.
Yes. Thank you, sir. Thank you, Dr. Shankar, for very exhaustive talk. Actually, what I learned from, I have learned a lot of things, but I came to know from your lecture that the main culprit is the inflammation. So,
yes, exactly.
Yeah. So, and we have got quite a few, cheap anti-inflammatory drug like non-steroidal anti-inflammatory drug. So, is there any role of using this non-steroidal anti-inflammatory drug, which are a very cheaper drugs? And by that, can we improve the this anorexia and other nutrition-related problem while we are treating these cancer patients?
It's too early to comment on that one, but having said that, metformin has been tried and it's still under being taken into many more other researchers, whether it can be an adjunctive therapy along with the chemotherapy. So the earlier results are really very encouraging, and maybe in the next coming couple of years, or maybe in the next 5 years, will definitely be very clear whether the pharmacotherapy intervention to reduce the inflammation will be having a better outcome. So that's what I can make a comment. But metformin, we have to really wait and look out for the interventional guidelines for that.
Okay, thank you.
Thank you, Satish.
Thank you, sir. Dr. Shivashankar really was an eye-opener talk. So regarding protein intake, 1 to 1.2 or 1.3, see for a 70 kgs vegetarian who is on chemotherapy for hemato-oncological malignancy, it's very difficult to give so much of protein diet, plant protein based diet. What do you advise actually? How do, just to give an example, what all do you say to consume to make up so much of protein intake?
Sir, what I can tell you over here is like we have a software built in our own TMH. We take the recall of the patient, and during the recall, we identify which are the foods he normally he consumes and which are the normal foods he discards. He doesn't want to eat that one. A very rough estimate does come to me saying that he's consuming around 35 to 40 grams of protein. So there is a deficit of 40 to 50 grams of protein. The guidelines also says the first is that you do the counseling. After the counseling, you see then if there is an improvement or not, then you can go on supplementation of that one. So if I feel that my counseling is going to work out, while talking to the patient, we come to know the patient will be compliant or not. Only during those 2-3 days of the chemo, post-chemo days, those are the days which will be challenging. Thereafter, again, they come back to the normal, and around 70 to 80% of recommendations they are able to consume. Supplementation comes to handy when I know that this patient is listening to me, but I know that either the logistical problems, financial problems, or the support system is not really very good, or maybe his digestive system is not compatible to adhere to my advices. Then I have to come back to the supplementation part of it. In the selection of the supplementation, I spoke around during the presentation, all those factors which will be dominating me, which kind of supplementation I need to be selecting for that.
Right.
Supplementation do come handy.
Thank you.
Thank you. Roshni?
What are your views on alkaline water? Because many patients ask this question.
Ma'am, the book gives a very good answer for that one, but not to promote that book. But yes, alkaline water, we really don't have to succumb to that kind of a claim. It's so sensible enough for us, the medical fraternity, to understand we have HCl secreted into our stomach. How far it is going to alkaline water, going to be remaining alkaline once you consume that one. And body knows to manage its own pH values. Blood knows to manage its own pH values. And how can this water really go into the cell and change the pH value? It seems to be a very lay person's discussion, but very effectively the companies have put it across to the people, and very well they have marketed it. And many people have, a lot of offers do come to me saying that, sir, behind one unit you'll be getting so much of money. Why you cut for just one word of it? But no, it is not true. And none of the international societies or even ASCO, or you may just name any kind of a society, none of them are really agreeing the claim what you mentioned about it. No, alkaline water has nothing to do with it.
Thank you.
Thank you. Dr. Anupama.
Thank you very much for the very detailed talk, and also I think big thanks to Dr. Agarwal, because raising awareness on this topic is so important. So what we find in the UK is, based on our experience, we follow up our myeloablative transplant patients very carefully with regards to their nutrition. And the moment we see a 10% weight loss, we actually commence enteral rather than parenteral nutrition, because we find that the chances of infection are lower. And also we find that in terms of graft versus post disease, we see less of that with the enteral nutrition. So I just wondered if there was anything that Dr. Shiv Shankar had any experience or any insight into this.
Ma'am, actually, I don't see the bone marrow transplantation patients, because that is being conducted in other center in Navi Mumbai. So the dietitians over there, for the last 3-4 years, there were no dietitians. So the doctor in charge, they themselves were seeing to that one. But having seen some experiences in that one, the GVHD, when the diarrhea and other things are complicating your matters, and any evidences which is available to us as of now, the glutamine supplementation, the probiotic supplementation, everything is a controversial kind of a thing. So the best way to go about it is, the safest way to go about it is a parenteral nutrition at that time. But having said that one, there is one intervention which is not being tried as of now, is a topical feeding. The topical feeding is something like 500 of volume of your enteral feed, may provide you around 1500 or 1800, 1600 calories, giving you around 60-70 grams of protein. And if we can meet this one through enterally without escalating or the inflammation and the diarrheal episodes, I think we'll be doing a wondrous job for that particular patient. So that topical feedings, which is someone can take this as a RCT and can try it out. A wonderful intervention. And yes, it will be definitely impactful. The outcome will be very positive, but someone has to do that. At my center at Tata Hospital, we don't do PM, so I'm handicapped to make a comment on that.
Thank you. I just wanted to know what happened.
Dr. Radhika. Unmute.
Thank you, sir. Probably this is the first lecture on nutrition I have ever attended. Thank you. That was a great knowledgeable. My question is, in our routine practice, 80 to 90% of the patients, hematological malignant patient, do complain of decreased appetite or 5 to 10% loss of weight and all, which we generally manage with commercially available nutritional supplements. So do we have any markers of measurement of nutritional status, which should alert us to take a professional nutritionist help?
Yeah, that's why I said it's a very lengthy process, madam. The comprehensive nutritional assessment is almost, it takes, for an expert, it takes 20 minutes. For a newcomer, it will take half an hour. And you all are so busy, we do understand, but you cannot really spend your quality time in nutritional assessment. So what everyone is looking out for a very short kind of a dose related kind of a nutrition intervention where I can address. So unfortunately, as I said during my presentation, there's not a single study which is supporting a random supplementation of nutrition has benefited any kind of a population. So it has to be, if at all supplementation has to be done, it has to undergo proper nutritional assessment. And after that, what is the shortcoming? As I told you, there are many factors which are included before the recommendation comes, and which is the last priority for me for the supplementation. And if at all something can be worked out, hematological cancers, malnutrition, as I said, 27% in the Western countries it has been seen. I may expect around 30-35% in Indian conditions, but I don't have data of to make a definite numbers for that one. The only thing is the fatigue is the most important thing. What I will be concerned regarding the hematological cancer patients rather than the decreased appetite. The decreased appetite is again the fallout of the fatigue aspect over here. And the physical activity, the lack of physical activity is going to compound the problem. So it is something like knitting all the dots and getting together to a center point. How much of supplementation and which kind of supplementation and when it has to be done. So which are the good days and which are the bad days. So we need to differentiate between them. And during the counseling, we keep on telling the patients, you have to identify your good and bad days. And you have to see the supplementation, which days you have to do and how much of supplementation is required. So if I can tell the patient, what is your normal breakfast, lunch and dinner comprises of how much of calorie protein, that will be equivalent to this much of supplementation of this what I'm recommending. For example, if I say you are consuming around 600 calories of lunch, for example, and if in that you are getting around 20 grams of protein. Now I have to, while supplementation, I have to tell, if I'm going to give product A, which is again, if you take 10 scoops of this product A, which will give you around 600 calories and 20 grams of protein. So either you go with the product, either you go with your meal. And if you feel that if you have consumed only 50% of it, then supplement that 50% with the product A, what I recommended. So the supplementation cannot be done randomly unless until you know what is the shortfall. The shortfall you have to calculate for that one. Then you have to just, we have a software, so where it becomes faster. Even an experienced one, it will take hardly 2 or 3 minutes. How much of rice, how much of quantity, what is the size of your chapatis and the dal, how it is liquid or thick. All those things, we take around 2 minutes to take the feedback, calculate it, and then we understand the shortfall of it. Then we'll say, you need to compensate here. And we feel if this is adequate, you don't have to take over here. This is the other area where you need to work out. Maybe you're not having breakfast, there at least you have to consider for that. Then again, the breakfast may be around 300 to 400 calories, not comparing to the 600 calories of the lunch. So a lot of calculation goes over there. If you want to really do a good work, then it has to be expert over there.
I know, so it's complicated.
Just a dosing. Dosing is a harmful thing. And the skillful supplementation, the patient is going to benefit throughout the life.
Thank you, sir. That was very useful.
Yeah. Thank you. Dr. Gopinathan, once again, congratulations to you. You have become the quiz master. So go ahead and question.
Thank you, sir. Thank you, sir. Thanks, sir, for the very nice presentation and understanding science behind nutrition. Sir, we recently had a patient of non-Hodgkin's lymphoma with diffuse small bowel involvement. The patient typically had large volume diarrhea, all features of malabsorption. So in these kind of patients, how do we decide upon enteral versus parenteral nutrition? How long to keep these patients on parenteral nutrition? So is there any guide and how do you follow these patients in your experience?
The diarrhea management, it is one of the most easiest. If you can go to our grandmother's advices, like you just keep your milk and go for a black tea with lime added to that one. That is a lemon tea, what you call, or you just go for the arrowroot kanji or sabudana kanji at that time. If that doesn't resolve, then the pharmacological intervention is very much required over there. We normally recommend these 2-3 interventions. Normally in 4 to 5 hours, the patient is relieved. And thereafter, slowly again, we ask them to go on a very mild diet. And maybe on the second day, again, they can go for a full diet. So this is what normally a diarrhea management we do. It can be induced by any kind of a radiation induced kind of a thing, or maybe a chemo induced diarrhea, or maybe a disease induced diarrhea. This is the normal intervention what we follow.
Right. How to address the, like TPN, how long to give and when to switch over to oral? It is all only clinical based, or we do have some laboratory parameters to do for it, sir?
Yeah, the clinical guidelines again state that the parenteral nutrition can be tapered off if at all it is started. So you find that the patient has increased his intake around 60% of the adequate requirement. Say, for example, if the patient really needs around 2000 calories, if 1400 calories is able to eat, or maybe 1200 calories is able to eat orally, then you can taper off in the next 1 or 2 days, and only the oral feeds can be continued. And if it is less than, as I said, 60%, you still have to continue. Maybe you can use a partial parenteral nutrition to meet the shortfall over there. So the benchmark over here is the 60% of the daily requirement of the patient. And maybe you will have a fair idea whether the patient's condition is going to be worsening in the next few days or not. Of course, we cannot be predictable predictable all the time. But normally you will have some ideas whether the patient is on improving, or maybe after 2-3 days he might deteriorate. So you can take a call on that. But 60% is what the guidelines is.
Thank you, sir. Thanks a lot.
Dr. Prashant.
Good afternoon, sir. Being a hematologist, I treat a lot of these ALL, lymphomas, myelomas, where we give pretty stiff doses of steroids. And when we are giving these steroids, when we tell the patients, you cut down on your fruit intake, they have massive disappointment of their life. They might not have never eaten fruit in their life, but they want that now. So at that point of time, do you advise us to go ask them to eat fruit and pharmacologically manage the sugars, or cut down on fruits?
Again, a very good question. As you said, some patients are so obsessed with the food intake, even the supplementation after 2 years also, they don't want to leave, even if they have increased by 20% of their weight. Even 20 kgs, I would say, not 20%. They were weighing 60 kgs during the treatment. After 1.5 years, now they're weighing 80 kgs. Still, they want the supplementation. So that is why, no, it is a harmful thing what we have done to the patient. So as I said earlier, it is the priority, it is a goal. My short-term goals, what they ask during the treatment, and the long-term goals during the survivorship, what a focus. All the guidelines do say that the healthy weight maintenance is the most important thing during the survivorship. And the patient, maybe earlier weight was around 80-85 kgs. Now I have come down to 70 kg. I want again achieve 85 kgs. Even though the 85 kgs is harmful for them. But the obsession of the patient, educating the patient, that is not the right weight, and you will be having maybe a recurrence, which is normally we have 30% of the recurrence cases of any kind of a cancers. So would you want to fall into the 30%, or would you want to fall into 70% of the safety? So, and that is why what kind of supplementation, or higher calorie ones should I be recommending, or a low calorie and good amount of protein? As you said, kids, should I continue with recommendations of the fruits should be still restricted, or sugar should be restricted, protein should be encouraged? It depends upon the what patient at that time the patient is carrying, and what weight I would like to achieve him in the near future, in the coming 3-4 months. Sugar restriction is a all-time restriction. Provided we tell them in between, if you have some event at home, some pujas are there, some birthdays is being celebrated, you don't have to worry. You don't have to be very so strict for that one. But a habitual consumption, some people, you go out, you have ice cream, you go have a faluda, you go and have a pastry. So these are the things which we are more concerned of. Once in a while, eating or consuming any kind of sugars, nothing is going to be bad for them. But during the active treatment, when you're trying to destroy the cancer cells, why should I give an ideal platform to that cancer cell to survive? So I'm actually reducing your treatment efficacy without anyone's knowledge. No one knows. The treating doctor doesn't know, the patient doesn't know. And if the dietitian is also not educated, they also don't know. They also say you can eat everything. So they are actually harming without anyone's knowledge. No one knows about it, and the treatment outcome is not as good. The same kind of a patient might have a good restrictions and have a fade up very good in a better way. But unfortunately, we don't have a data. But international studies do indicate that the sugar restrictions during the treatment and after that, yes, the results are really very encouraging. Now, someone will challenge us, the dietitians. You show us RCTs. Unfortunately, your ethical committee will not permit you to conduct the RCT of such a kind of a nature where you will give 50 grams of sugar to one patient, one category of patients, and the other patients you will not give anything. So that is why you will not find a RCT worldwide where you can say, give me an RCT where sugar is really show a real good outcome. So we are handicapped over there, but we have to believe, you have to trust the evidences which are available and published. In the last 100 years, I would not say in the last few years or maybe in the certain kind of a papers, I would say. There are thousands of papers published in the last 100 years since the Warburg what he started speaking about. But somehow it is never brought into practice. Believe me, sir, I am following all these websites since the time internet was made available to us. I am going back to around 15 to 20 years back of my practices, where jellies, fruit juices, you can say milk cream, and such kind of things were prominent recommendations on ASCO's websites, on AICR's websites, WCR's websites. They all have vanished now. They are no more over there. So why is it that when they changed their recommendations, and they're so clearly stating that you have to restrict even for the survivorship. They're not talking only for the Western people. They're not talking only for the active treatment. They are saying even for the survivors, you have to just avoid all added sugars as far as possible. Sugar cartel is the biggest cartel in the world. It can change even the government of any country. So it is so powerful. That is why the alternative sugar substitutes were never allowed to come up. Unfortunately, they were termed as carcinogenic, but of late, very recently in the last 5 years, except for the very recently published one research where only 27% of the sucralose has been found to be carcinogenic, but it is not a conclusive study. But no other than any study has come and said that alternative sugars are will cause cancer. So why not use the alternative sugars? And why we are so obsessed with the bad sugars which we bring home around 2 to 3 kgs and we consume, the entire family consumes.
Thank you. We have short time left, so I request the questioners to ask pinpoint question. And Dr. Shivshankar, you will also have to be brief because I like to cover all the questions.
Agreed, yes.
Dr. Priyanka.
Good afternoon, sir. Thank you for that exhaustive lecture and briefing. So my question is, sir, for myeloma patients, when the patients are taking this RBD protocol, most of the time they say there is dysgeusia. So what is a remedy for their dysgeusia? Because it is like a prolonged therapy. They have to be on maintenance. LEN has to be given for 2 years minimum. So what do you suggest for that?
Dysgeusia, you said, madam?
Yeah.
The pain during swallowing, correct?
Dysgeusia is a loss of taste sensation.
Yeah. So, madam, I did mention about one slide over there where the change of consistency of the feed was being mentioned over there. So even the loss of taste is going to be a kind of a dysphagia over there. So what we normally tell them, they can use a straw and can make any liquid kind of a feed. The moment they don't like the taste, they try to avoid the feed. But if they can use a straw and directly if they can drink by keeping the end point of it deep into the tongue, so they don't actually have to taste. They just have to suck without tasting anything. A bad taste will be infusing not to consume the feed, but no taste at all and not tasting it at all will do no harm. So during such time also we use a lot of either the liquid preparation from the kitchen or from the ONS, whichever is available, the right kind of advices.
Okay, sir. Thank you.
Thank you. Dr. Thomas.
Thank you, sir, for the wonderful and informative lecture. I have one question, sir. If a patient of acute lymphoblastic leukemia on asparaginase develops pancreatitis, what dietary advice will you give and how long will you advise those dietary restrictions?
Obviously, it will be acute pancreatitis. We don't have to restrict any feeding to this patient unless until we have a very elevated pancreatic enzyme available to us. But having said that, if the patient is very nauseated, doesn't want to eat anything, anorexic, and during that time you can always go for a peripheral TPN implementation. But if you can feel that the patient can afford to have at least maybe around 500 to 1000 ml of daily feed through either enterally or orally, which is a very challenging, depending upon how aggressive the pancreatitis is there, what is higher grade. So depending upon that one, you can take a call on that. Even if the patient can tolerate around 1000 ml per day of a liquid diet, I think you don't need a TPN over there. Having said that, again, do you need to restrict any kind of a nutrient into that one? Like, should I restrict a fat, or should I go with the normal fat recommendations? If I don't have the amylase reports, lipase reports, then it becomes very difficult. So your input is very important for me to restrict any particular kind of a nutrient over there. If blindly, if I want to plan a diet, I would go for a MCT based diet rather than a fat restricted if the patient is not overweight.
Okay, sir. Thank you.
Thank you. Kunal? Unmute. Okay, we'll just come back to Kunal. Dr. Gunjan.
Thank you, sir, for a very informative lecture. My question is regarding any special considerations for nutrition considerations for the patients in post-transplant period.
Remission
should be the
or
advice?
doing remission or needs
After transplant, during remission.
Again, this has to be the survivorship kind of a intervention. What we will be looking at it. So then again, we come across, if at all any prevailing, the traces of any kind of symptoms are still prevailing or not. The first priority will be, if at all any prevailing symptoms are there, I will address that issue. Thereafter, I will try to achieve the ideal body weight for that particular patient through the building of muscle mass rather than just the increase or decrease weight. What is the requirement? Should I be asking the patient to decrease the weight or just to increase the weight? That will be again a secondary aspect over there. And as I said, healthy dietary advice, which will also prevent the recurrences of the diet. Of course, it won't be 100% right to claim that definitely a healthy diet will 100% will be refraining from the recurrences of it. But yes, of course, the attempt will be very humble one. See that the disease doesn't recur again. I'll be giving a good amount of anti-inflammatory diet. We'll be asking the patient to be physically active and what all the lifestyle they have. If at all any curtailment of lifestyle is required, accordingly it will be advised.
Thank you. Thank you.
Thank you, Dr. Gunjan. Dr. Kunal, what you can do is you can log out and again try to log in or just type your question. You have put your question. So Dr. Kunal wants to know any specific supplements to prevent chemotherapy-related toxicity like peripheral neuropathy.
For peripheral neuropathy, it has been seen some studies are in favor of recommendation of omega-3 fatty acids, 0.3 grams per body kg weight per day. It has been recommended. If at all, but the studies has to do more with the omega-3 coming from the fish oil rather than the vegetable source. So we have a challenge with the Indian population who are vegetarians over here. So that is the only thing. If you would like to use a vegetarian source of omega-3, as flaxseed oil and other things are also available, and fish oil omega-3 are also available.
Thank you. Before we take the second round, we will take some question from the audience. Dr. Krishna Ratnam wants to know what exactly is anti-inflammatory diet.
I did show a lot of list over there. I would just mention what all your vegetarian diet is normal. Normal vegetarian diet is a anti-inflammatory. Like all vegetables, I would say, all your pulses, all dals, all complex carbohydrates coming from your grains. Your fruits are also, but once it becomes juices, it becomes inflammatory. But if you eat the fruit along with a good amount of fibers and phytonutrients, it remains anti-inflammatory. Along with that, white meat is an anti-inflammatory, but red meat is an inflammatory one. When it comes to the milk, the lactose is inflammatory in certain conditions, but if at all no clinical conditions are there, it will remain as an anti-inflammatory. So there are certain things which are directly fall into the inflammatory or anti-inflammatory conditions, and there are some which are based on the conditions. So your more or less vegetarian food along with your white meat is a non-inflammatory food items, in short.
Thank you. Dr. Robinson wants to know, even a cancer patient needs sugar. So how much sugar is dangerous?
Actually, cancer patient doesn't need sugar. And sugar is actually not required for the body because it has no role in our body. It has role only when we are hypoglycemic. We are not in our senses to bring up the blood sugars. That is the only time where the sugar's role comes into the effect. Or else sugar for not only cancer patient, any kind of a patient, even for you and me, it is not required.
Thank you. Dr. Raghuvendra wants to know, besides protein, carbohydrate, fat, and vitamins, do you have a table for the essential nutrients daily optimum intake as parenteral and enteral nutrition?
The minerals and the phytonutrients are the other things which which are also required for the patients. And fiber doesn't fall into any kind of this thing. Of course, it has been scientifically classified as a carbohydrate. But these are the other nutrients which will comprise of a wholesome nutrition. The proteins, carbohydrates, fats, then I said the phytonutrients, and then coming the minerals and the trace elements. These all things do comprise.
Thank you. That's it. Dr. Rajwarkar wants to know what nutrient get depleted from the body more during the chemo agents.
Very difficult to answer how far the cytokines are active. If the cytokines are active, both the fat deposits and the muscle deposits are going to be compromised and they will be depleted. So it depends upon if the patient is not highly inflammatory condition, and if the patient is having a good meals, and the CRP levels are into a level kind of desired levels, maybe around 1 or 2 or 2.5, something like that. Again, this patient will be faring better than other inflammatory condition patients.
Thank you. Dr. Smita Kayan has put a question. How can we assess the muscle mass clinically? Is there a quick assessment tool?
Questions again. Anything like if you have a body impedance analysis machine, that will give you a good analysis of the body composition, how far the fat and muscle mass is there. Then you have CT scan, you have sonographies which are being projected as the best equipments which can detect the depletion of the muscle mass into the patient. But then whether these departments are going to adhere to your requirements. If I can ask my CT scan department, the radiologist wouldn't say that I am going to provide you all these information for that. So these are the things, where even though the systems are available and all these cancer patients very frequently undergo CT scan, they don't really pay for my requirements. But it is understanding between the various departments and how far they work together. So they are the best one. The CT scan, the sonographies are the best one, and instantly they will give you what are the changes that has happened with the muscle mass when the patient reported earlier and as of now.
Thank you. Dr. Akanksha Garg wants to know, how do you counsel a patient with food anxiety?
It is the total counseling, I would say, to build up their willpower and tell them, if you don't follow my diet, what is the repercussion it's going to happen and why it is important. It is the education, it is the motivation, it's a wholesome kind of our personality comes into over there. Because we understand the patient is able to eat, but he is depressed. Then I have to take the help of the psycho-oncologist. So yes, of course, then I would recommend the patient over there. I need to improve the compliance to this patient. Maybe if not, I might need help from the speech swallowing therapist. But if the patient anxiety is because of the dysphagia. So what is the cause? Is it the finance which is causing the anxiety? No, I don't have money. That is why I don't want to buy awareness. No, I don't want to because protein is an expensive thing. Whether it's a natural or awareness. So what is the anxiety cause? Is it the patient's attendant who is not interested enough in looking after the patient? So we need to identify and yes, we change the route of the counseling to that patient.
Thank you. We take the second round. There are a few questions, Dr. Gunjan.
Hello. Sir, I have a question regarding the nutritional consideration in gut GVHD patients. So, how do we plan the?
Yeah, as I said, it depends upon the kind of flare, how high the flare is. The higher the flare, you take down your decision to feed the patient. So if the patient is quite good and can tolerate the feeds, maybe as I said, the tropical feeds, they are not yet been tried in many of the patients. That is the one thing which can actually relieve these patients of feeding by just 500 ml drip wise throughout the day, which can give you around at least 1,500 kilocalories. And having said that one, we don't have to try too many things over there by giving the glutamine and probiotics and other things to resolve the diarrhea over there. Or it's all trial and error. So you just be as a nutritionist will focus on the symptom. But exactly if anything is wrong into the system, you need to specify to us exactly this is the thing which is wrong. In any way you are going to do probiotics or prebiotic or maybe a soluble fiber, the patient is not going to tolerate. The causative factors, if it is explained to us in the right way, maybe we can change the intervention. As I said, there will be 2-3 interventions where you can just recommend a black tea with lime juice to address the diarrhea, or maybe you want to give a high amount of soluble fibers. Both interventions are opposite to each other. But which is going to resolve the issue for this particular patient? It's again a trial and error kind of a thing. Ultimately, I want the patient to tolerate the feeds. That is more important. Then I can think about the nutrition aspect in the coming few hours or maybe the coming few couple of days. Again, TPN is always available to you.
Thank you, sir.
Thank you. Dr. Upendra.
Sir, my question. So do you recommend neutropenic diet to all our patients of hematological malignancy? Because some of the guidelines say, so all of patients of hematological malignancy, do you recommend neutropenic diet? Because some of the guidelines say the ESMO or IDSC guidelines do not endorse routine neutropenic diet because of lack of evidence for decreasing infection or all-cause mortality. So do you recommend for all patients or some select patients like AML or transplant patient, the neutropenic diet should be followed, or for others we can avoid neutropenic diet?
No, we recommend to all the patients, There was during one of the webinar, one of the oncologists did question that when all the parameters are really good, neutropenic counts are good, why you still would like to give a neutropenic diet to this patient? The answer is you never know when the neutropenic condition does come. Does the patient is going to report to me? No, he's going to report to me once in a month. So I really don't know when that episode is going to occur. First thing is that. Secondly, the studies what you spoke about, there is no difference between a neutropenic diet and a normal diet consumed, and there is no outcome. All these studies are conducted in the Western countries where the hygienic level is very competent enough comparing to the Indian conditions. So we really cannot compare those studies to the Indian conditions and say you can go and eat anything. Our patients will go down and around the hospitals and go and eat all Chinese food and even the vada pavs and whatever the kind of thing, whatever they feel like mouth-watering kind of a thing. They might eat anything. And you never know, infection can, it's just a matter of just a split of a second where they can acquire an infection and they will be having issues with that one. And how much of efforts they have to put thereafter, and including your efforts as well.
So we have a well-to-do patient, very educated, hygiene status very, very good. So do you still recommend for all hematological oncology patients to go for nutrient diet?
Giving a selective area, as you said, a very rich person with lot of good hygienic environment, and there are many people to take care of it. But yes, all these actions have been under control. Still, we will say that you have to be careful, but you don't have to be obsessive with that one. But other parts of the population, we will say you have to be very strictly following this one. I don't want you to go out and have even coconut water over there. The way it is being handled, the fruit juice, again the way it is being handled, the street foods, the hotel foods. Each of the hotels will really follow a really good hygienic conditions. I wouldn't even trust even the 5-star hotel. Sorry to say that one. What happens into the kitchen, no one knows who is going to consume except for the employees over there who has access to the kitchen. So I wouldn't trust anything. Yes, of course, if the family members do say that, yes, we are going to adhere to a very clear all the hygienic recommended adherence are there, yes, we give a little bit of freedom to them.
Thank you. Roshni.
Which patients who are normal on chemotherapy should be prescribed a low-fat diet, and what is the definition of low-fat on follow-up, which we recommend for, say, breast cancer patients on follow-up?
Madam, there is nothing like a low-fat diet definition, I would say, because defining a low-fat diet for a for a 60 kg person will be different than an 80 kg person. So I would say the requirement of the fat consumption for that particular patient will be more important. If you would like to quantify this at any cost, it will be the 10% of your total calories should come from your fat content. Now, within the fat, which are the good fat and which are the bad fats, and what is the composition of your PUFA, MUFA, and saturated fats. So these have to be really come into the context of complementing each other, other than randomly saying, okay, you are taking 30 ml of fats, that's more than enough. But if the patient is weighing around 75 kgs, 30 ml will not be sufficient. It has to be increased to 35 ml or maybe 40 ml. So now, what is my goal over there? Whether that 75 kgs is acceptable for me, maybe his height is around 175, 180. So I don't want this person to change his weight. I just want this person to build the muscles. So I would better increase the protein content and not to reduce the fat content over there. So if I want this patient's height is something around 165, I want this patient to from 75 kgs to come down to 65 kgs, then I would better reduce the fat content from the diet as well, bring down to 8% or maybe 7%. So what is my requirement? What is the long-term goals for that particular patient would determine how much of allowances I would allow this patient.
Thank you, sir.
Thank you. Dr. Deepak.
Sir, my question was, there are a lot of nutritional supplements available in the market. Can you just let us know, are there any adverse effects which arise out of these? Because many people tend to consume it even after they are off their chemotherapy.
Yeah, I think you might have missed out on a few things what we discussed. Yes, there are some supplements which cause allergic reactions. There are sometimes of ONS. The reasons are very difficult to reason out why a particular ONS is not tolerated by a particular patient. And thirdly, that is why we tell the patients even after the treatment. During the treatment only, we tell you whenever you are coming to the meet your consultant, you have to come and see the nutrition clinic as well, even if the treatment is complete. So that is why we, even after 3 months or 6 months or 9 months, when they are called for the follow-ups, we ask the patient to report to us because we want to monitor their weight over there. So our nutritional intervention for a cancer patient never gets complete and over till the patient is surviving.
Okay.
Thank you, Dr. Charles. Just last part, we have few questions by email. Is there a vegetarian diet which is rich in copper?
Quite difficult to answer you because copper is something which is very rare. It requires in micrograms in very less quantity. And a normal diet of nothing dominating, like someone will say, okay, I'm eating a lot of paneer or milk products, and someone is going to tell you I eat a lot of vegetables. But the requirement is so low, any kind of a normal diet would suffice your requirement. So you don't have to really obsessive, unless until you have some inborn errors regarding the copper aspect, you have to really consult an expert in that.
Thank you. The second question has come is, there are dietary items which are supposed to improve platelet count, like kiwi fruits and papaya leaf. Is there a science behind it?
No, I have not seen anything such kind of a thing. Not only that, I would like to add over here regarding the wheatgrass juice as well, or the papaya juice, the papaya leaf juice, which is for the dengue purpose, which has been also seen into the oncology aspect as well to improve the platelets. However, the kind of a nutritional intervention, the platelets are going to change after a few days, either by your pharmacological interventions or maybe a natural process of the body maintenance. So, but having said that, if they are going to eat that, believing that the platelets are going to improve, whether it happens or not, the fruits are good, so let them eat, but unless until they make it into a juice. So, not connecting it to the platelet level, let them eat that.
Okay, thank you. The next question is, you talked about safety of sugar-free tablets, etc. Do they lead to Alzheimer's disease and impair your memory?
I'm sorry, I'm not able to answer this one. I don't have knowledge for this.
All right.
As far as I know, answer will be no, but I may be wrong.
Fair enough. The other question is, in a vegetarian, besides milk product and pulses, are there other sources of protein?
Very tough for the vegetarians. These are the only two things. Then again, soybean is one thing which can be a savior for these people. So dals and pulses have to be a regular feature for these kind of. There are other alternatives, quinoa and other things, but you cannot term them as a protein-rich one. They just have a better content of protein compared to the other cereals. So if the other cereals are giving you around 3.5 grams of protein, the quinoa will give you around 5 grams, added 2 grams of protein, but they will not double the protein compared to the non-vegetarian source. So what you said, the answer lies with your question as well.
Right. One last question is, I think somewhere you must have mentioned ghee to be added to the dietary items. So is ghee safe for elderly cancer patients who may have associated cardiac illness?
As I said, the maintenance of PUFA, MUFA and TSF is that is the saturated fats, and ghee falls into the saturated fats. So it's very important unless until the patient has some cardiac history over there. So I would go slow over there rather than recommending. But I know if the patient is okay, I want to increase the weight, or maybe the patient is underweight, quite okay kind of a patient, why should I deprive him of the ghee content over there? Having said that one, I would advise him not to exceed more than 10 ml per day.
That was the last question. So, Mr. Shivshankar, thank you very much. You have given a wonderful lecture, as many commented that this is the first time they've heard what you spoke to them. And then a very elaborate Q&A session also speaks of what were the deficiencies in learning of the people, what were the confusion, and they have tried to sort their problems through you. And you have done that very, very elegantly. I'm
Thank you, sir.
Extremely grateful to you for sparing your couple of, three hours almost for us and educating us. I think everybody would benefit, and in turn, they will make their students champions in the dietary management of their patients. And
Sir, can I appeal something to the learned audience over here?
Yes.
If at all possible, we all can come together and frame the guidelines for the hematological cancer patients. It won't take much time. Even on online also, we can work out. You can define one day, and I'll get some onco-nutritionist to participate in that, and maybe everyone will benefit. The fraternity, the patient, and we as well.
Fantastic, definitely. Why not? It can be worked out very easily. Today, the communication skills have become so easily repeatable. One last request: if your talk is open for everybody, we have a website, and if it's okay for you, you can allow us to put it on the website, because many people might not have heard it today. So
I do give my consent.
Optional, totally. Yeah. Thank you so much, and thanks to Dr. Reddy's Lab for supporting our academic activity. Thanks to Perfect Square for executing this whole thing flawlessly, and thanks to all our large number of colleagues who spared their time and asked very, very intelligent questions, which have made. We have about participation from, once again, 25 countries. So everybody has benefited today. So thanks, and have a wonderful lunch with your family. Bye-bye.
Thank you, sir.
Thank you. Thank you. Bye.